Now, CHIL launched in 2020 and was created to bring together people like all of you, machine learning researchers, health policy experts, industry leaders, clinicians, who care deeply about integrating AI and technology with, in the healthcare space in a technically rigorous and human-centered way. In 2022, CHIL became a conference under a new nonprofit, the Association for Health, Learning, and Inference, ALI. We really like those letters. We just rearranged them, apparently. And ALI has grown to encompass multiple conferences and events a year, and is striving to help bring together the right people to talk about thought leadership and to organize the right kinds of events that this community needs. Now, speaking of events, ALI has two notable upcoming events I want to highlight very briefly. First is the Machine Learning for Health Symposium happening in December in San Diego, California. The call for participation is already live. Submissions are due in September. Please check that out if you're interested. And in addition, we're very excited to announce the first ever ALI Summer School to bring together people in this community to help build and equip the next generation of leaders with the tools, knowledge, and resources to advance AI in health. If you'd like to learn more about this or our other events, you can sign up for our mailing list and stay in touch that way. Now, ALI is run and led by our board of directors and our fantastic staff who have a hand in making all of these events possible as well. But we're also always actively seeking partnerships and collaborations in this space, focusing on opening data access and creating socially meaningful impact. If you or your organization or folks you know might be interested in helping us do these, please don't hesitate to reach out or come talk to any of us during the event today. We have a number of board members and folks at the event with us today. Now, speaking of our event today, we have a fantastic program that we're really excited about, featuring fantastic keynotes from pioneers shaping the future of health AI, poster presentations, which will happen just behind that black screen over there that you probably saw being set up as you walked in, on various topics in the health AI space, panels and roundtables on what are especially urgent topics in these crazy times, from generative AI to translational impact and responsible innovation. And we have our doctoral symposium, which showcases the next generation of researchers and ideas. Now, of course, none of this would be possible without the incredible efforts of our organizing team, our program chairs, reviewers, volunteers. We're deeply grateful for everyone's work in making this event a reality. Now, of course, speaking of thanks, we also need to thank our sponsors for not just the unconference that I mentioned before, but the entire main conference as well. We are here today in particular thanks to the Computational Precision Health Joint Program at UC Berkeley and UCSF. CPH has generously provided us with this wonderful physical space, the facilities, and arguably most importantly, lunch, which will be available later today. And we'd also like to thank our gold sponsors, ADIA Lab, Optum, Google, and Schmidt Sciences, and our silver sponsors, GSK, Apple, and Silicon Valley Bank. ADIA Lab is a computational science and AI lab based in Abu Dhabi, UAE, with interests in health science, climate science, and digital economy. ADIA Lab's mission is to help develop a knowledge-driven economy in the UAE through high-impact research, development of a skilled workforce, and translation of research IP into commercially viable entities. They also organize summer school, funds research through grants programs, and do lots of other exciting stuff. And if you're interested in learning more, you can connect with Dr. Shadab Khan, who is here at the event today. Optum AI, our other gold-level sponsor, alongside Google and Schmidt Sciences, is working to transform the healthcare journey through responsible AI and ML innovation. Their vision is to create the most effective, affordable, equitable, and engaging healthcare solutions for patients, providers, and payers. And they have a great booth outside, so you can stop by their table to learn more about their open positions and partnership opportunities, alongside some of the research that they do in this space as well. Google is introducing the Health AI Developer Foundations. HighDef is a collection of open-weight models and companion resources to help researchers, developers, and the industry at large tackle the challenges in healthcare and the life sciences with AI models. You can hang out with the HighDef engineers at the Google booth throughout the conference to see demos and ask questions and chat with their team to learn more. Now, before we get started, a few housekeeping reminders. So the conference program is available on our website. You can access it through the QR code there. All attendees are also required to adhere to the code of conduct, which is posted outside on a board and is accessible online as well. Now, restrooms in this building are not available on this floor, but if you go one floor up or one floor down, you can find them there. There are stairs right next to the water fountains outside, too, if you want to go up that way. And also hang on to your badges, because you'll need them to access the space and the event for both days. And after the event is over, you can recycle your badges by leaving them at the registration desk at the end of the day. Finally, we encourage all of you to connect with each other and with us intellectually and personally, ask hard questions, share your work, attend a session or a poster outside of your domain, say hello to new people. CHIL is really not just a conference, but we hope a growing community. And like the field we're shaping, it's at its best when it's collaborative, critical, rigorous, and human-centered. So with that, we'd like to welcome you officially to CHIL 2025. Thank you. And in particular, to kickstart our program, I'm very excited to introduce our first keynote presenter, Dr. Maia Hightower. So Dr. Hightower is a recognized healthcare executive and thought leader specializing in digital transformation, responsible AI, health equity, and clinical quality. With extensive experience as a C-level healthcare IT executive at leading organizations, including the former executive vice president, chief digital and technology officer at a major health academic system, and two-time former Chief Medical Information Officer, Dr. Hightower has successfully pioneered initiatives that measurably enhance clinical outcomes, community impact, and operational excellence. As the founder of Equality AI, Dr. Hightower has advanced standards in AI quality, safety, and trustworthiness. Her unique blend of deep clinical expertise and executive experience positions her uniquely to guide your organization through critical transformations and strategic initiatives. So without further ado, please join me in welcoming Dr. Hightower for our first keynote.
Thank you so much for that kind introduction. I think we're going to do a little laptop switch and get situated. So you guys are the dedicated ones that came so bright and early at 9 a.m. Although I do always appreciate the Bay Area conferences because 9 a.m. for many of us is like 10 a.m., 11 a.m., maybe even noon, which is amazing. It does not work as well the other way around when it's a 9 a.m. In the East Coast. So when I was invited, I was invited to speak in October 2024. Let's just say a lot has changed since October 2024. And if you heard a list of those things that I'm kind of known for when it comes to giving a talk, health equity, responsible AI, AI policy, a lot of these things have been completely upended in the last 6 months, right? Like, it's a very different world when the very thing that I'm so passionate about, health equity, is on the list of forbidden phrases in your NIH grant. To talk about the future of AI-enabled care, to have to hold back and say, do we want a vision in which everyone benefits and it's just and fair? That used to be something that I would say with vigor. And now we're in a time where you say it and you have to be brave to say it, right? Like, a lot has changed. But the other thing that I'm often asked to talk about is sort of my leadership journey and what has that path been like to be a physician, to be an informaticist, to be a healthcare leader. And I think one thing that has been consistent despite all the change that has happened is being true to our values, right? Because healthcare is a human right. And when healthcare is a human right, when you fundamentally believe that, it doesn't matter what's happening in the political world. It doesn't matter what's happening in the policy world. What matters is the individual decisions you make when you're developing your models, when you're solving your problems, and that you hold true to your values. So I just wanted to make sure that all of us remember with that calling, why we entered into healthcare in the first place. Now, you as computational geniuses, right? You guys can do a whole lot of things with your talent. You can go to outside of healthcare. They'll pay you twice as much, maybe even 5 times. You'll get equity in some company, and you'll solve some problem that has nothing to do with healthcare. But you chose healthcare for a reason, because you wanted to make a difference. You chose healthcare often for personal reasons, because you've been impacted by disease. A loved one has faced the burden of cancer or heart disease, and it's impacted you as an individual. It's impacted your community. It's impacted the way that we deliver care, and you wanted to make a difference. So if it's one thing that you take away from today or that you take away from this conference, is that fundamentally, you entered into healthcare for a reason. So I'll give a little bit about my background. I love Berkeley because it is my hometown. So in many ways, being here back home reminds me, again, of the values of, say, Berkeley, a place where justice has been a rich part of its history, where the freedom of speech, of academic independence, has been in an integral part of the history of this place. And so just as I grew up in the aura of Berkeley, I'd like you guys, when you leave this place, that you take a bit of that aura with you. That combination of justice, that combination of innovation, of academic excellence, and you remember that that is the core being of why you went into healthcare in the first place. So these are my lovely parents. My lovely parents still live 2 miles away from here, and they very much have helped guide my path when it comes to why I'm here today. But so much is actually because of the aura of Berkeley. I went to Head Start at the age of 2. I went to Berkeley Public Schools throughout. And this place very much helps to remind me of what's important in our day-to-day. So with that, I'll say obviously there's a lot of change that's going on right now. And there's plenty of good change, especially when it comes to the power that AI brings to healthcare, right? There is this incredible opportunity to fix a broken system. Healthcare is broken. Healthcare needs your expertise. And a positive way of spinning healthcare is broken is that we can unlock value. Right? That's often how we'll frame or measure impact in healthcare, through the healthcare value equation, where we increase quality, decrease cost, and improve experience. And we already know that AI has created so much value, especially when it comes to reducing the administrative burden of healthcare. That's probably one of the use cases that has most been celebrated over the last year, 2 years, is really being able to return to clinicians the joy of clinical practice, right? Like, no doctor went into healthcare to be a secretary, to learn how to type, or to be a coder, to be able to translate to health insurance companies, justify why a clinical decision has resulted in a recommendation for clinical care. No doctor, believe me, went into medicine to do that, and yet that is the burden that the last 20 years really has placed on clinicians. And AI is already providing incredible value, whether it's being able to use ambient documentation. I mean, that alone, can you imagine the electronic medical record being a joy to use? Like, come on, like, that thing is a behemoth. But we actually are getting to that place where clinicians can now connect with patients and no longer be tied to a keyboard. We're getting to that place where so many of the AI interventions are around coding, are around prior auths, the revenue cycle, so that clinicians no longer or less have to face that battle with the insurance company. So much value there. And then as we move forward into this arena of multimodal AI and being able to not be tethered to just clinical EHR data, but this wonderful, rich amount of data that's in imaging data, in genomic data, and in voice, transcription, audio, video. There's just so much data that we now are able to you all are able to translate into actual solutions that provide precision identification for an individual. So I'm not going to go into like the wonders of multimodal AI. As I was joking with some of my table mates, it's like talking to you computational experts about multimodal AI is like me talking to a cardiologist about 4 chambers of the heart. there it goes, lub-dub, right? Now, so you guys are the experts, just as you are the experts in AI evaluation. So I'm not going to talk a lot of that. But what I am going to talk about is, the incredible challenge of translating AI into healthcare. And this is a quote where Ulrich Harowitz, who's the chief medical officer of Microsoft, at one point said, the impressive barriers of translating AI to healthcare practice may actually result in no change to the practice of medicine in 5 years. It is really challenging to go from your innovative model to actual impact at scale. And so 80% of AI projects fail, and why is that? What can you do to make sure that your really important innovation actually makes a difference? Well, understanding the barriers to success are so important, and then being able to navigate them. One is just the sheer complexity of healthcare and life sciences. Now, how many of you work in a healthcare system? Yeah? How many of you have worked at 2 healthcare systems? Were they identical? No, exactly. If you worked at one healthcare system, you worked at one healthcare system. If you worked even within Epic, the electronic medical record, if you've been an technologist in one instance of Epic, it's just one instance of Epic. Often that variation between even the same software implemented in a different healthcare system can be incredibly difficult to navigate. The second is immature AI governance, how decisions are made in healthcare systems. There often isn't a rhyme or reason to how a decision is made or the decision-making pathway. Again, that variation between 2 different healthcare systems. So you as an innovator have to understand one system, but it may not translate to another. And then AI regulation uncertainty. We were in a period where there was sort of AI safety was the framing, and now we're in a period of sort of AI laissez-faire and uncertainty. And then real concerns about bias and the ethics of AI. And so I still, you can say health equity is a verboten topic, but it still is incredibly important because of all the forms of injustice, of inequality. Injustice in healthcare is the most shocking and inhumane. So that fundamental truth does not change, even if our environment tells us that it may have changed. And so I want to talk a little bit about digital redlining. It's the practice of creating and perpetuating inequities between already marginalized groups, specifically through the use of digital technologies, digital content, and the internet. And so when we think about, again, the electronic medical record is a great example of digital redlining. How many of you use the patient portal? Yeah, have you logged on to, I'm kind of Epic-centric or Epic biased, and I spent most of my career in Epic organizations. And how many different languages is the patient portal, MyChart, available in your institution? How many? 2, exactly. And we still haven't addressed that problem, even though we know that there are easy tools today to be able to translate patient portals into pretty much any language. But it's been consistent that often there's 2 languages, Spanish and English, maybe a third. Some really advanced health systems will have 4 or 5 different languages. But that would be an example of a digital redlining where the tools that we find really helpful as a native English speaker can access our medications, can access our doctors, access even appointments, and yet it only be available in 2 languages, thereby creating a hard line of access for those that don't speak or understand or read English or Spanish. And so that's just one example of digital redlining. Another example would be race-corrected EGFR. Before the race correction was removed, there was essentially a hard line on creatinine level in which if you were below the line, you were eligible for, say, kidney transplant. If you're above the line, you are not. And race correction effectively changed the line based on one's race. And no one in healthcare really questioned it because it's a number, right? It's like the creatinine's below their threshold or above the threshold, and hence they're no longer eligible for care. So those are just examples. And the history of AI bias in healthcare is not new. It's not since ChatGPT's hallucinations. That isn't when the first instances were actually identified. As early as 1976, you all, and especially those of you that are in computer science, have long understood that bias could be embedded in code. So Weizenbaum's book, Computer Power and Human Reasoning, suggested that bias could arise from data encoding assumptions embedded in computer programs. So again, you all were the first to identify that this is a problem. As early as the 1980s, algorithms were used to automate decision-making on who got to be entered into medical school. This is actually a model that was deployed in the UK, and then they found that it discriminated against women and ethnic minority groups. In 2016, ProPublica, again, the computational community were the first to really call out bias in an algorithm used to predict recidivism and say, hey, this is actually causing unequitable harm to one population over another. And then again, back to healthcare, probably most notable or impactful is Obermeyer's work here, he's here in Berkeley, on racial bias in an algorithm for healthcare, predicting healthcare costs. And so lots of examples when it comes to the history of bias. I think one thing that's really important is that when it's embedded in code, it scales. So if I, as a doctor, am biased, right? Like if I make a biased decision, it's me and that patient, just one-on-one. If I, as a healthcare executive, within, say, the electronic medical record, I develop a policy, my impact is for maybe if it's a large health system like UCSF or UC Stanford, may impact, say, 1 million patients in that area. But if your code is deployed in hundreds of health systems and it's biased, it's flawed, it can cause harm or be exposed to millions, 80 million or more patients. And so that's why what do you do? I mean, often we'll think, oh, the clinician's bias, that's bad. Well, yeah, but when it's embedded in code, it can scale to incredible proportions. And I'll give the example is Obermeyer's paper, AI Bias Detection and Mitigation and Population Health Risk Model. You guys are all probably very familiar with this particular study. Of course, it's one that's often cited as an example of harm from AI bias. And the root cause was actually just a simple labeling error, an assumption made by the data scientist that cost or spend in the US claims is equitable or the same or correlated to risk of disease progression, risk. And it turns out in the United States that Black patients spend less while being equally sick than white patients. Plain and simple, there's many barriers on why, but it's actually been pretty well documented that even when Black patients are equally insured, have same socioeconomic status, doctors even, this actually was a doctor study, that for one reason or another, Black patients tend to spend less, they have less access to healthcare resources. It could be trust issues, there are many, many layers on why. But choosing such a proxy for risk systematized within the model that inequity that already existed on a societal level and amplified that to the point where on a a national database, the researchers could see the precipitous decline in case management referrals, because that's what the resource that this particular model helped to differentiate or help to distribute resources for, that they could see a decline. And by simply choosing a different label, instead of cost, they chose the things that actually make sense, the number of problems on the problem list, whether diabetes controlled or not controlled, like more real world estimates of risk, then they were able to fix the model. And so the story isn't necessarily the fact that this occurred, but that the researchers estimated that over 80 million patients have been exposed to this model or models, variations of this model. That was because it was deployed in hundreds of health systems and population health management platforms, and why the impact, the harm, was so measurable. When it comes to cost, maybe $1 billion in cost when it comes to chargeable case management services. And then when you actually think about the harm that may have been done, how many of you have tried to navigate healthcare for a loved one that has multiple medical conditions, that has complex care needs? Is it easy? Is it intuitive? Is it like, oh yeah, when a patient needs it, they get it? No, the healthcare system is incredibly challenging to navigate. And what they were helping to provide is identify who would benefit from case management services, the ability, the actual resource to navigate the healthcare system. And so the true cost was to patients, to families, on not having a resource to navigate one of the most complicated systems in the United States. So who knows what the actual true cost of this one model had on our society as a whole. And so bias, as we covered, this particular example of bias occurred during the modeling process, and perhaps you could say the evaluation and even the post-deployment process. But bias, of course, can occur at any stage of the AI lifecycle. And when we think about bias, I think that we do need to sort of reclaim the word bias when it comes to the statistical definition of bias. It's deviation from ground truth, systematic error. We have so many other political and other layered meanings, but when it comes to AI evaluation, it's systematic error, that deviation from ground truth, and making sure that we're creating models or building models where we're evaluating for that risk. So that risk can occur throughout, from data creation, data acquisition, especially in healthcare. The clinical care data has non-random missingness. So certain populations will be overrepresented in the emergency department, maybe underrepresented in preventative health and subspecialty care, and it's not random, it's non-random missingness. How that data is created in the model development process, so the decisions you all make when you're identifying labels, because unfortunately that perfect label rarely exists, that ground truth label rarely exists, so you're manipulating and trying to figure out the closest approximation to the truth, to the evaluation process. And so there's a whole methodology. Again, I don't need to tell you guys about the methodology on AI evaluation, but it is important for you all to go through the steps, right? Because you may be the only one in the room that understands how to perform the evaluation process. And so this is where you all become so incredibly important, especially in the post-deployment, as well in the post-deployment phase. You may be the only ones that are making the decisions, because if we don't have regulations that are telling us what to do, then it becomes an individual collective decision that we're going to do the right thing. And so when it comes to bias mitigation methods applied throughout the life cycle, there are a number of different publications on best practices for responsible AI, including making sure you have your organizational structure in place, that AI governance methodology in place at the systems level, that there's a formal process for identifying what problems to solve. Because even at that problem formulation level, who gets to decide? Who has the power to decide what problems to solve? Are we going to solve problems around rev cycle and payment, which are all incredibly important because no mission, no margin, no mission. But at the same time, are we going to solve problems that actually impact patient care? Right? And then there's the question around best practices on algorithm development, on product evaluation, and so on and so forth. So all of these things you know, there are many examples, many playbooks, and it's all, of course, part of most PhD programs. So this is one example. One of my colleagues, Brett Bolio-Jones, who is actually on the board of CHIL, and he's created an automated AI monitoring system at UChicago. So he's looking for feedback. If you guys are interested in how to automate some of this stuff, you can reach out to Brett. There are other researchers as well that have created AI monitoring systems that are semi-automated. We haven't gotten to full automation yet, but that's definitely an area of active investigation. So no talk on responsible AI. It's complete without regulation. A talk about where we are, current state of regulations. This is what it looked like pre-November 2024. The federal government was on a pretty nice clip. HHS was on a pretty nice clip when it came to creating some regulatory frameworks and practices. ONC had released HTI-1, which was its AI transparency requirement for EHR certification. CMS had finalized its final rule on limiting the use of AI in Medicare Advantage programs. The ACA had been updated for the Office of Civil Rights Section 1557 final rule against AI non-discrimination protections. Clearly, all of that was upended in January. So Trump's executive order called Removing Barriers to American Leadership in AI essentially revoked all of Biden's executive order on AI safety. So those regulations are still on the books. Question is, where they're actually enforced or not. The Office of Civil Rights, as of December, had been actively talking about or getting feedback on how they're going to actually implement and the ACA rule. Of course, now it's like crickets. And I think one thing that's is right after the executive order for removing barriers to American leadership in AI, there was a number of states. Initially, there was only like 3 or 4 states, California being one, New York, Colorado, that had active state-level legislation. But quickly after the repeal by Trump's new executive order, a number of states, over 20 states, had started to work on their own legislation. Well, buried in the one big, beautiful bill is a provision banning states from enacting AI regulation for 10 years. Now, initially, when it passed through the House, it was like a ban. Like no state could pass any kind of, or enact any kind of AI legislation. It would be not enforceable. But there has been some pushback within the Senate, where right now it's been sort of modified, where it actually is, the penalty is federal assistance on broadband coverage. So the penalty isn't as stiff as just complete prohibition. But we don't know where this is actually going to go. If this one big, beautiful bill passes, then there's going to be incredible disincentive at the state level for regulation. Hence why your collective individual actions become so important. Because what that shifts the responsibility to institution levels, but our institutions are under attack as well, right? So unclear how much you can rely on institutions, but then that leaves individuals and teams and tech companies to say, okay, as part of quality assurance, we're going to make sure that our models don't cause harm. And so back to, I talked about healthcare as a human right. It's just one, it's the broadest of principles that are the foundations for responsible AI principles. So it just kind of becomes, the responsible AI principles are a subset of that statement, healthcare is a human right. So responsible AI principles are really around robust and reliable AI that is respectful of privacy, safe, secure, fair and impartial, transparent, explainable, and accountable. The JAMA, a number of leaders, well, when AHRQ was an actually funded agency, had commissioned a convening of leaders to come up with some principles. And some of the guiding principles really are about these responsible AI principles, including equity and fairness. And so from principles, you get into frameworks, a number, at this point, over 300 frameworks. So there's a lot of responsible AI frameworks, just pick one. No, I'd say, actually you can just kind of pick one, what works for your organization, but some of them on a national or international level. In the international level, we have ISO 42001. It very much aligns with the EU AI Act. At the national level, the AI Risk Management Framework, so still very applicable on how to incorporate these principles into practice. And then a number of institutions have playbooks. Chicago has a playbook, the Algorithmic Bias Playbook. Duke has a playbook. Stanford has a playbook. CHI has a playbook, so there's a lot of playbooks. I think what's most important for a lot of healthcare, a lot of individuals, when you're developing your AI governance framework, is this kind of alignment. It can be overwhelming to boil the ocean, but if you take your international standards, map out your national standards, and then your healthcare specific standards, and then layering on any kind of regulation, you can kind of map into what you ought to do. So places like Stanford and Duke and Chicago have somewhat figured this out, but it's really expensive, right? Like, are we creating a system, a framework where we now have healthcare systems that have good AI governance, that are innovative, that create these amazing tools for their providers, and then you have federally qualified health systems or community hospitals that just don't have the resources, don't have the talent, don't have the funding to do such a thing. So Brett Bolio-Jones and his team as well have developed a framework for right-sizing AI governance for institutional capabilities so that an institution can pick and choose, depending on where they are in their AI governance life cycle, to be able to identify just like the minimum required at a particular level instead of having to boil the ocean all at once. And it's called the Healthcare AI Governance Readiness Assessment, HARA. And so what that enables is a partnership type model, and this is what we propose as a responsible AI community partnership model, where larger healthcare systems can help smaller healthcare systems in their AI governance maturation. Similar to how healthcare systems will often provide EHR services, MSO services, Epic has a program called Community Connect, where large health systems provide Epic and technical support for health systems, for smaller health systems, having some similar type of model for AI governance. And this is actually a model that has been proposed by Duke as well in their AHAP framework. So I got the little 5-minute sign, hence why I was speaking a little fast at the end there. I think I now have 2 minutes. I will say that we each have a role to play to ensure the future of AI is safe, effective, equitable, and benefits everyone. Now that we have less to rely on when it comes to guardrails on the federal and perhaps even state level, we often are going to be relying on teams, on individual decisions, and your training as computational informaticists. So the take-home message is really making sure that AI governance is a priority at your institution, at the scope that you are able to impact, even if that ends up being at the team level, and that you're including diverse voices in your governance models, that you're doing subpopulation analysis. At the very basic is just making sure, does the model perform as expected above threshold for all of the various subpopulations that my model may be exposed to? Very simple. You guys know how to do that in your sleep, right? So at the very least, making that available to the communities that you serve, and then driving innovation when you see these gaps. So I'm going to leave with a vestige of equality AI. Obviously, equality AI did not make it in the last 6 months. But one thing, our manifesto, I think, is one that resonates today. So data scientists, you are the newest members of the healthcare team. As such, the Hippocratic Oath applies. First, do no harm. Therefore, pledge to adhere to the following ethical code and swear to fulfill, to the best of our ability and judgment, this covenant. So 1, we respect that algorithms have power. What you discover has power over life and death, treatment and non-treatment, distribution of scarce resources. It's an awesome responsibility and must be faced with great humbleness and awareness of this privilege. That we respect healthcare data, privacy and security, that we don't lose sight that each data point is a unique human experience, digitally recorded. So for those of you that are at Stanford, my dad's data is at Stanford. And so when you create something, right, like that man is represented. It's his human experience that has been digitally recorded and is in that EHR. And now part of the broader data set by which you manipulate. We respect the hard-won scientific gains of those whose steps we walk and gladly share such knowledge. We'll not be ashamed to say, I don't know yet, and call on our colleagues with the skills of others when the skills of others are needed. And we value a culture that combines an agile mindset and processes with authenticity, personal wellness, and team fulfillment. And then I will end with, we bring modern technology methods to solve healthcare's most challenging problems: inequity, bias, unfairness, and we believe in AI for good, AI that is fair, and AI for equity. So with that, thank you very much. I open it up for questions.
Wow, thank you so much for such an inspiring talk and for sharing your vision for a more equitable digital future in healthcare. And so we'll be taking some questions, and if you could introduce your name and a little bit about yourself, I'll come around and share the mic. Any questions?
If nobody else, then I'm going to come up.
Yeah.
I'm Roxana Donishchu. Thank you, first of all, so much for coming and opening our conference with your talk. As one of the program co-chairs, one of the things we wanted to do, which you did so beautifully, is set the tone of what our values are for this conference. And so we deeply, deeply value responsible AI health equity. My question for you is, for those of us who care about this issue, it's been a very difficult time. And what advice do you have to the young researchers, the young faculty, about how to navigate and persevere during this time? Because obviously it's not the first time there's been setbacks in this very important, battle.
Yeah, absolutely. The first setback was just ignorance, right? And that was actually pretty straightforward because you combated that with information. I think this audience isn't alone in this question. So I've given talks at University of Kentucky, at Virginia Mason University. Like, these are areas that definitely have, at the state level, in addition to the federal level, almost like bans against talking about health equity. Less so about responsible AI, and so I do think using the language of computational methodology actually helps. And so you can say a lot of things where you know that the end goal is responsible AI and health equity, but you say it in a way that's mathematical language and hopefully get funded through essentially navigating the barriers or the verboten terminology. So I think that's one technique that I know some of you have deployed, and some have been successful at getting their grants funded when they change the vocabulary, but through using more precise definitions on methodology and being able to leverage that for the same outcome. So I think that's definitely a technique that seems to have helped, that seems to have worked. That, and I think that there's always sharing. So from all of you all, when you do have successes, share how you were able to accomplish that success. And perhaps it's going into industry where before you thought you were going to be in a role that was, pure academic research, but you find yourself entering into industry. Once in industry, you have a lot of power to be able to shape how your product is going to be developed and be able to incorporate that responsible AI principles, especially around safety, around privacy, around explainability, and being able to incorporate that into your product development lifecycle. So that too, I think, is a path that I've heard yesterday that people were taking. Even if their boss, their CEO is like, we're gonna need to go fast and break things. Well, you know what? Breaking things in healthcare can often mean lives, or you might have broken the trust of the clinician, and it may be the end of your actual startup. So you need to be very careful and make sure you're building trust, even when you're in industry.
Hi, my name is Megan. I was actually leading part of Google's privacy for a few years, and now I'm doing a startup on women's health. I was working with a professor at a major university on women's health project and a collaboration. And he told me that his grants were cut because women's health study now research is not inclusive enough. And he asked, like, well, you give me some men with ovaries, I will include them. It's getting ridiculous. So I'd love to hear your view and the thoughts on like women's health. And I'm maybe preaching to the choir here. A majority of modern day health care is based on male data, mostly white male. And we have a huge challenge, a problem with women's health. So I'd love to hear your thoughts. And we're hitting some bumpiness, but I think there's a ton of bottoms up, like a sort of demand from women. And if you look for search query trend on Google, there's a huge amount of more demand from women wanting to know more science and more advocacy, more knowledge, and any thoughts you have on that would be appreciated.
Yeah, that is a great question, because women's health has really been targeted. I think that those that have been successful at navigating and sort of reformulating their grants have used words like disparities. Health disparity apparently is still okay. They've used words like, instead of social determinants of health, which is not okay, environmental factors that impact health and healthcare. Whereas women's health, it's kind of hard to change the vocabulary. Maybe if you shift to ovary focus, I don't know. I don't have any good answers. I do think that there is some small uptick in foundation grants, but even that is like small. It's not going to meet the need, the gap that's been created with the absence of the NIH funding. So I don't have any good suggestions other than, lobbying congressmen, lobbying one's politicians, and then thinking creatively. Maybe it is in the innovation space where companies like yours, where you have the power and to be able to figure out what is going to resonate with your marketplace of women consumers, and is that sufficient to be able to fund further development where it's actually market-driven. So I think there will be a lot of market-driven shift when it comes to women's health, and us as women ideally will, that will resonate within our spending. But that's a really tough one, because that one, I haven't heard of any successful strategies on reframing women's health in a way that has resulted, at least in the traditional funding sources. Has anyone have any information to share? Like how for women's health specifically? No? Anyway, so if you do have some take-homes, share it. But at least apparently, if you use, instead of SDOH, environmental factors that impact health, that seems to be an acceptable substitution. Similarly, health disparities to some extent.
Hello. Hi. My name's Emma. I am a practicing doctor in the UK, and I also have a PhD in machine learning for health. So I'm in the middle of this space. And for me, I was quite moved by your pitch on values, and I truly share those values as well. I think the problem that we have is that we need to bake in a system of aligning those values with how the system works.
Yeah.
And I think, for example, in the UK, the way that the healthcare system works there is that I get paid the same no matter what I recommend for the patients. And I wonder what the position of opportunity is to bake in those values here. Regulation being one, but I wonder if, from your perspective, if you have thought about other ways to bake in those values other than, I suppose one thing is to reiterate those values and show healthcare leadership. But I was wondering if you had any thoughts on that. Thank you.
Yeah, so definitely the most impactful is when it's at a systems level. Absolutely, as you described. But systems can be big and national. They can be, so for example, in the UK, and please record our history for us, because we cannot reliably say that our history is being recorded accurately. So we look to the international community to record our history as it's occurring here in the United States. But the systems-based approach 100% is the way to go, but we can think of systems at a federal level, we can think of systems at a state level, you can think of systems at an institutional level. And I think at the institutional level, this is where we may have a lot of impact. Maybe we don't have impact at the federal or at the state level, or maybe we do have some impact at the state level. Here in the state of California, there's been a lot of initiatives to try to encode that systems thinking, especially around responsible AI and health equity, at a state level. And then at the institutional level, at health systems like Stanford and UCSF, where AI governance very much is rooted in these values around equity and fairness. And so hence the policies and the practices within that institution. But the challenge is that then that scope is limited. As you just saw, as we talked about the impact of scale at a health system, it's much smaller than at say, even a product that is disseminated across a nation or world. So for industry, I think this is an opportunity for those in industry to systematize within their product development lifecycle. And so then that may still have even equal to, or even greater impact than some of the federal guidelines and federal guardrails could have had if you have your big tech companies and small, startup innovators that are baking in these systems levels commitment to values and to principles of responsible AI and fairness in their product development. So I think that's the kind of like, how you parse it. But we may be in a situation where it's down to that smaller unit of teams and individual. So any system can be expanded or contracted depending on how you slice that system.
Thank you so much, Dr. Hightower. Please join me in giving her another round of applause.
I am thrilled to present her as my friend, collaborator, colleague, mentor. Ida is just a force in the field of AI health. Dr. Ida Sim is a professor of medicine and computational precision health, co-director of the UCSF-UC Berkeley Joint Program in Computational Precision Health, UCSF's first chief research informatics officer, and a primary care physician. Dr. Sim's research focuses on technology and policies for large-scale data sharing of health data. She is co-lead of Jupiter Health, which I have heard we will hear a lot about today, co-founder of OpenM Health, a nonprofit organization that defines an IEEE global open standard for patient-generated health data interoperability, and co-founder of Vivly, the world's largest data sharing platform for participant-level clinical trial data. Dr. Sim is a member of the National Academy of Medicine and the American Society for Clinical Investigation, a fellow of the American College of Medical Informatics, and recipient of the United States Presidential Early Career Award for Scientists and Engineers. Dr. Sim, thank you so much for being with us.
Thank you, Dr. Dunn. So happy to be here. I really appreciated the talk by Dr. Hightower. Really sets, I think, the most important set and stage for what we're talking about, which has to be grounded in equity and what we're really here for all peoples. I'm also a co-director with Maia Peterson of the UCSF-UC Berkeley Computational Precision Health Program. We are co-sponsoring this conference, and just want to welcome you to Berkeley, and also my UCSF hat, welcome you also to UCSF as well. So yeah, today talking about harnessing computational tools for real-world precision health, and I think you've heard a lot about sort of the real-world challenges already in the talk beforehand. Let's just get started. I think when we hear the term precision medicine, precision health, large parts of our community tend to think about basic science research. And I call that kind of below the skin research, from DNA, up to proteins to cells, organisms, and up to organisms like humans. Of course, we are at an inflection point with AI, with huge opportunity for quantum leaps, right, across these biological scales. So tremendous excitement there. At the upper right of this slide, here, we see the human as an organism, like a rat, or it's an organism. There is AI, of course, above the skin, which I think is really more the focus of this conference. And here, I want to make that jump from the human as an organism to the human as a person, right? We are people. We have preferences, we have desires, we have lives that we live in the context of our friends and family, in the context of our communities, from the city to the state to the whole world. And so we have tremendous opportunity to impact precision health for us as people, not as human organisms, but as people. And AI promises that through consumer health, of course, and also in AI-enabled clinical care, and AI-enabled public and community health as well. Those are sort of the pressure points that AI can bring to bear. My rather bold claim to you today is that our current health AI ecosystem, I think, fundamentally misunderstands the problem space, and that much of the investments and the solutions are in the wrong solution space. It's a rather bold claim. Would love your comments on thoughts. This is an evolving thesis. But I come to this after 20-something years practicing medicine. I'm a primary care physician, done work in innovation, in academia, of course, and working with industry as well. So my talk will be split into two. The first section is going to be exploring the problem space as I understand it, and then looking at the solution space as well. So let's see. Let's start with the first point, which is we need to treat people and not diseases. So as I said, I'm a primary care physician. Yesterday I had clinic. It goes from 1 to 4:20. I usually don't have 10 patients scheduled. I don't know how that happened. Usually I have about 7 to 8. And then I had a drop-in patient also who had an acute heart attack at an outside institution and dropped in clinic, so there were 11 people. I think you can just scan this list. This is from 1 to 4, 20 minutes per patient. And you can see their ages. You know, the youngest one is 68, I guess. I've been in practice for 20-something years, so these are patients I've had for 10, 15 years. You can see the types of conditions they all have. I'm just going to quickly run through what we talked about. The first patient, follow-up on a UTI, we spent the entire time talking about her husband, who's in dialysis as an end-stage cancer. Second patient, Charcot-Marie tooth disease, declining. When should he move to assisted living? What does that mean for him? Third patient, trouble swallowing, getting better. You know, I'm working him up. I'm still worried he has cancer. I need to refer him to GI. Fourth patient, diabetes, worse. Hypertension, worse. Cause, situational anxiety. You can probably imagine what situation is giving her anxiety. Talked a lot about that. Bronchiectasis with mycobacterium infection, and also chest pain, wondering if she has heart disease. Uncontrolled diabetes, chest pain, new shoulder pain, chest pain, hypertension, new cervical lymph nodes from a woman who has breast cancer in the past, tremendous situational anxiety from the current situation, flaring with her lichen planus from her skin, cerebral palsy patient. Any reflections on this? What strikes you? So we hear a lot about like specialist care. I'm a primary care doc. This is what I see in clinic. What strikes you about this afternoon's care? Just comments, just throw it out. Yeah. Not enough time, 20 minutes each. I did not finish at 4:20. I finished at about 5:35. I had AI scribes. My charts are not done, let's just say. Any other comments? Ouch. Yeah, you know, my perspective is to spend as much time as I need per patient, and I fall behind. But these are all my patients. All these patients know when it comes to them, I spend all the time I need with them. Any other comments? Yes, back there. I might not, but I know them really well. But there are things where I had to go back, so I pre-chart. I look at the chart first, remind myself, and I spent a lot of time looking up this, osteoporosis story about this one particular patient. But yeah, there's a lot of history in here, right? A lot of data. Any other comments? Pardon? Aging population, yes, absolutely. More complexity. So these people have multiple conditions, right? And that's one point I want you to really understand. Multiple chronic conditions. 6 in 10 Americans have a chronic disease. It's the ones down listed below. 4 in 10 adults have 2 or more chronic diseases, okay? So when you talk about treating a person, it's their constellation of diseases. The American Heart Association in October of 23 defined this cardiovascular kidney metabolic syndrome, which I think is really good because that's what I treat. I do not treat heart disease or lung disease or diabetes. I treat people who have constellations of these diseases that wax and wane over time in terms of their severity, in terms of the composition of diseases. These multiple chronic conditions are a major cost driver, so 90% of our annual use healthcare costs are driven by these major chronic diseases that are listed here. And of course, there are major drivers of death also. Worldwide, 80% of all premature non-infectious disease deaths come from heart disease, cancer, chronic lung disease, and diabetes. And that's increasing globally, okay, globally. But do not think of these diseases independently. They come together. They come together. And yet, we focus so much on clinical care, maybe because we're thinking about diseases. And then it seems natural, right? Well, if you're thinking about like heart disease, oh my God, that's so serious. We need to work with the cardiologist. We need to work at the hospital. We need to work in the emergency room. It seems very understandable. This approach, I think, is actually quite problematic. I'll share with you the ecology of medical care. This is a very interesting framing. The bottom line is looking at medical care through the pinhole of a healthcare system, especially an academic healthcare system like UCSF or Stanford, is really ignoring the bigger landscape, okay? This is work by Larry Green, published in 2001. It's an update from analysis he did in 1961. And the numbers were pretty much the same. Out of 1,000 people that you just grab out from our population, and this is US specific, about 800 report symptoms, about 327 consider seeking medical care. This is in 2001, right? So they're not like going to Dr. Google, which everybody goes to now, or Dr. ChatGPT. 217 visit a physician's office, 65 visit complementary medicine, 21 visit a hospital outpatient clinic, and it goes all the way down to where 8 are hospitalized, and fewer than 1 out of that 1,000 are hospitalized in an academic medical center like UCSF or Stanford or Harvard or wherever. And yet, where do we always work? We look at the MIMIC data set, we look at the UCSF, or we work with the Stanford data, amazing resources, but please remember that that captures such a small part, a small part of health and healthcare. There's so much else out there, okay? So the majority of healthcare happens outside the healthcare system. The majority of chronic disease management, which I would say is the key area of disease that we need to look at, are done by the patients themselves. Who was it who said I had very little time? 20 minutes for all those conditions. I'm not the one who's treating those conditions. They are. They are. I'm there as a co-pilot, I'm there as an assistant, but they're the ones who are managing their disease. And yet we don't help them with it very much, do we? I hear a lot of nods. And the disease prevention and wellness, which are important if we're gonna get ahead of our costs, that happens out in public and community health. That happens before people hit the healthcare system. So we really have to expand the problem space. It is consumer health, it is clinical care, it is public and community health, and what can AI do in each of those spaces? So really advise that we expand our thoughts about where the problem space is. Sometimes when the problem space is too big, we can kind of get lost. So I think it's always helpful to have a grounding problem statement. Any of you who are doing your dissertation now, the single most important thing is to ask the right question, right? So I'm gonna propose to you a problem statement. What if every person can get the best proactive care and self-care they need based on their complete data for their specific mix of conditions? And it is a mix of conditions. And it has to be within the context of their clinical and their life situation. I have patients who are CEOs of companies. I have patients who are in Section 8 housing, which is, unstable government-funded housing. I'm really worried about that segment of our population. They'll come from vastly different backgrounds, and their considerations are different, their resources are different, their life preferences are different. We can't ignore that. And as I said, we want people to take care of themselves, and when people take care of themselves, they're not really that interested. I mean, they are on maybe their creatinine, but they want to know how they're doing, right? They want to optimize. We want to optimize how we're doing. So these are the kinds of things that we really want to optimize, as well as the sort of hard clinical outcomes, if we might consider it that way. So I will be talking more about patient-generated data today. This is data from, obviously, wearables, fitness trackers, sleep trackers, home monitors, smartphones, Internet of Things. We can imagine that this is going to continue to explode. That's typically sort of objective, quantitative data that's captured from sensors. There's also qualitative, self-reported data, patient-reported outcomes that might come from questionnaires, and these things called ecological momentary assessment, which is just a very quick ping on your phone. You know, are you anxious right now? You know, do you want to smoke? You know, are you fatigued, right? Like right now, you don't have to remember, wow, how have I been over the last week, and do I aggregate how I'm feeling into a scale of 1 to 5. It's like, how are you feeling right now? So we have a lot of technologies to capture patient-generated data as a window into how people are doing, you know, in between those 20 minutes that I'm seeing them in my office. Just a comment about how conceptually we think about patient-generated data impacting chronic condition outcomes. I think we tend to think very mechanistically about our bodies and about drugs. There is a mechanism also for how data impacts outcomes. And the way data impacts outcome really has two pathways. One is through the one that we're maybe more used to, is through the provider, the clinician. I get data, I interpret it, I get insights, I treat the patient gets better, right? You're used to that. There's a whole other pathway, which is patient gets data about themselves. They get insight, or maybe they don't. Maybe they get motivation. Maybe they feel that self-efficacy is improved. I believe more that I can do what I need to do. All those things are important, and in fact, I would say that that's even more important, because in the end, that's how people get better. They do take their meds, they do exercise better, they do sleep better, they do come to the doctor's office. It's the patient who takes care of themselves, and data is a way to help them to do, to take care of themselves as well. And together, the partnership between the clinician and the patient, that's how we get people better in the context of multiple chronic conditions, for the outcomes that we care about, both in terms of the hard clinical outcomes and in terms of the outcomes that matter to patients. Okay? So the AI solution for this kind of problem statement, as I'm putting it forth to you, is extremely promising and exciting, right? We've got multimodal data, we've got patient-generated data, we've got electronic health record data, we have AI, all of you in the room that's going to, building these solutions that give us insights, that give us predictions. How do we get from where we are now to the vision that we want to get to? And my metaphor for this is that we have 1,000 flowers blooming. Many of you in the room, right? You've got your own flowers, probably more than one each. But with 1,000 flowers blooming, you can end up with a great case of allergies. What we really want, actually, for each patient, if we're thinking about precision health, is we want a bouquet of the right flowers for that person, arranged in a pleasing way for them, right? That it all works well together and it looks nice. And it works to improve health outcomes. But not just a single bouquet, and not one for like the GI patients or the primary care clinic, right? We want a bouquet that's different for each and every single one of us. Some of us are gonna want blood sugar, sleep, and activity. Maybe over there, somebody needs, anxiety and weight and, something else, right? And it's gonna change, because you're gonna get sick, you're gonna get better, you're gonna get a disease, you're gonna, recover. So getting a sense of the trajectory of conditions over time means that this these bouquets need to mix and match over time, even for each of us. Is that what we're generating now? Does our system give us the capacity to build these solutions that meet each of us in our individualized precision health? I would say no, okay? No, in fact, not at all. I think to get there, we need an ecosystem of modular, standards-based, composable solutions, which I'm going to say Jupiter Health is our big proposal for that, so I will get to that, okay? So that's sort of setting the problem space. Let's turn now to the solution space. And what I think is going on, this is the way I'm seeing it, is that we have an overfocus of AI for healthcare systems. This is a chart from Rock Health. Many of you know them. They're just a fantastic group that aggregates a lot of information around digital health investments. The only thing you need to see here is there was a huge spike in investments up into the billions and billions in 2021. This is right around the time of COVID, of course. Huge investment in telehealth. And then there was sort of called a digital health winter. And, you know, drop in investment, drop in IPOs and exits. Lately, you know, very recently, excitement in the Omada IPO, of course, and ones like, you know, a Bridge AI with tremendous investments. We have some unicorns. So AI, obviously, a lot of interest in there. What is going on? So here, just direct you, this is from 2020 to 2024. So let's look at last year. The number one value proposition for investment is treatment of disease. And it really is treatment of disease. It's not treatment of patients, it's treatment of disease. Non-clinical workflow, that would be probably prior authorization, right? Billing, maybe referrals. Monitoring of disease, that would be sensors and wearables. On-demand healthcare, absolutely, right? App-based, chat-based. Clinical workflow, I certainly need help with that one. And then you see consumer health information at number 6, right? But tremendous focus, the first 5 are all over in this one part, right? And this seems natural. I think this is a reflection of the conceptualization of the problem, which is we need to treat diseases. And then the solution falls from that. We need to treat those diseases through specialists in the healthcare system, primarily, okay? And so how is this working out? So I was recently Chief Research Informatics Officer at UCSF. I'm not anymore, but I'm well familiar with the pain in a clinic and in a health system. These are some of the pain points that we see from UCSF when we've got tons and tons of companies coming to us to implement, you know, their special company product. Number one, technical and governance. Dr. Hightower talked about this. Incredibly challenging, the governance. But technically also, the projects, each of them, companies come to us and they rebuild the same data ingestion and storage infrastructure. We have to evaluate the security, the cost. We have to worry about governing it, overseeing it. Just a huge, huge overhead. Huge overhead. And then the company goes out of business and we do it again. Doesn't seem right. Patient trust. When there's so much fragmentation of the AI and the data flowing in, and you don't know where the data is coming in, where it's going out, and why is cardiology asking me this and cancer is asking me the same thing? Why are you asking me this over and over again, right? I don't even know what you guys are doing. That's kind of what we hear from patients. Our vision, of course, in a health system is we want to get to precision medicine. We want to put our data together. We want to compute across our data. But the data comes in a heterogeneous form. The collection methods are different. The formats are different. The consent around them is different. We can't put it together to make the best use of the data. And if we're also thinking about workflow, each of these systems, solutions that might be sold to us, might want to provide a clinician with decision support through their own interface. So maybe I might have a system that tells me how to optimize diabetes, and then I have another system that optimizes how I treat hypertension, and what, do I have to go to a different website? You know, it's just super confusing, right? And I've got Epic, UCSF uses Epic. So it's not it's not tied together. So basically, the thing really doesn't work, okay? So from the healthcare system perspective, and for those of you who want to sell in healthcare, this is what it looks like on the other side. Multiple pain points. So what's an approach? One approach is to say, well, let's just go with Epic. Let's just forget all this, confusion. We go with Epic. Epic has a very expansive vision, and there are lots of pros for a health system to do this. One is that the Med Center has full control. Everything's within Epic. For example, for us, lower security risk. We understand that security boundary, right? All the clinical units that use the same approach. As a resident or a physician, if I'm inpatient, outpatient, I'm in cardiology, I'll use the same approach. Remote data is all stored in Epic. You can't bill for something if your data is not in Epic, okay? So that's easy. Clinicians can see, if you bring in remote data, like a wireless blood pressure into Epic, then it's all within the same interface, same sign-on. Device agnostic, only to the extent that you integrate it into Apple HealthKit or Google Fit. That's one way that external device data gets into Epic. You could consider that MyChart is a trusted one-stop shop for patients. I think we mentioned MyChart, and from one end, it's like, wow, this is great. Like, this is one way, and all the patients can go there. I tell you, my patients absolutely cannot use MyChart, even if it's in English or in Spanish, cannot use it. Most of my patients are Chinese speaking and can't read, actually. Epic is doubling down on AI. They have hundreds and hundreds of AI solutions teed up in what's called Nebula. So you just buy Nebula, and you just sit there and wait for the AI solutions to come down the pike, right? Bingo, your problem is solved, okay? So I think it's a very reasonable strategy, very reasonable strategy. There are, of course, some cons, right? You are restricted to using Epic's AI and decision support. And I'm not going to go into it, but there are studies out there about how inaccurate they are, let's just say. And of course, there's a lot of bias, and we're not ever going to know, because we don't have the data. And the solutions just come down, and it's very difficult to validate them. Epic is coming out with a monitoring approach as well. I don't know, that's handing over a lot to Epic. The interface for clinicians is challenging. The interface for patients through MyChart is challenging. It's basically restricting commercial census to whatever Epic decides. MyChart does not support patient-facing decision support. It is purely a send a message to your doc. This is your, call this number to get a referral, right? There's no decision-making going out to the patient. It's very healthcare-centric. And of course, the strategic direction for AI then becomes completely dependent on Epic. And for an academic medical center like ours, where our faculty do research, there is very little way for our research to get implemented into that, right? So our CPH students, many of you are here, we work very hard to get your innovations into the clinic. But it's, if we have a lockdown Epic strategy, that's not going to be quite so easy, okay? And so really, given the market forces right now and Epic's dominance, really that is perturbing the solution space. It is Epic, then there's Cerner, of course, but Epic is really the dominant market share. Over 70% of hospitals, 43% of acute care hospitals are in Epic. And so huge investments in the clinical care space, much less on consumer health, almost none on public and community health. Epic does have those other domains in sight. Epic has everything in sight. But if we look at it, emerging companies are sort of like wedging themselves in here, right? You have to contend with Epic's dominance. So Abridge is doing well because Abridge now has a partner with Epic, And so I use Abridge clinically as a separate thing, but once it gets built into Epic, you can imagine that company's going to be much further ahead because, they're partnering with Epic, sort of gone on the inside of the walled garden, right? So that's the commercial markets field that is there right now. There was a question earlier about aligning incentives with Valley as well. in the US, it's commercial incentives, right? So that's kind of where we are. And then with the investments also, then you look at the clinical indicators on the right side, and huge investment in mental health, cardiovascular oncology. Again, these are primarily investments in diseases, So, and of course, because you're all like computer scientists here, if you're optimizing for a local, you're not optimizing for the global. And here, the local is a disease, and the optimal is the person, is the patient. I think that's really what we're trying to go to. So I'd like to ask yourselves, are we ever going to achieve, this problem statement? You can have your own problem statement. But I think what we're seeing is that we have 1,000 flowers competing, and much of it is competing in a walled garden, which is Epic. Epic is very good at building very, very high walls in their walled garden. Some of them are, some of the flowers are off in a field of their own somewhere. And, ask yourself, do you think this is going to come together in a way that's really going to give us what we want? My answer to that question, obviously, is no. So I think we need something different. There is a better way. And Jupiter Health is where we're coming to on this. We need a new ecosystem, right? It needs to be scalable, it needs to be modular, it needs to enable and reward the kind of solutions we want to the kind of problem statements that we might pose as we think of a different problem space. Think about constructing our problems differently. And what we want to come out on the other end are these individualized bouquets. And there'll be new flowers coming, and new AI solutions, and new sensors, and new digital biomarkers. So exciting. But if we don't have that sort of ecosystem to generate and reward the right kinds of solutions, I think we're just in the wrong, eddying in the wrong solution space. Okay? So the rest of the talk here, I want to talk about the essential components of Jupiter Health. First up is data and data standardization, and then we'll step through the two. So, we think about EHR data a lot. Remember that healthcare is only a small part of health. Don't just go to the EHR, It really reflects a small part of health and healthcare. There's a lot of other data. That's why I think patient-generated data is really important. There's all kinds of other data, your digital exhaust, like your how you spend your money, your social media consumption. That all tells us something about your health. But let's just focus today on patient-generated data, sensors and patient-reported outcomes, and EHR data. They are really quite different. As you see here, the target user is different. The perspective is different. The location, the data features, as you can see here. I just want to call out that EHR data, which is the standard there is FHIR, Fast Health Interoperability Resources. It really is for enterprise healthcare. It really is. The perspective is clinicians, administrators, episodic care, defined data sets, and something called the US Core Data Interoperability Data Set. Super useful, that's but it's data and data exchange for healthcare system coordination, really. Okay, enterprise focus. Patient-generated data, very personal, very life-based, very atomic data, very dispersed, different companies, different consent models. It's just all over the place. Noisy, very noisy. Sleep biomarkers, like, do we really understand what we really are doing in sleep? No. Hopefully in 2 years we'll know more, in 5 years we'll know more, but tremendous amounts of change. Power and data usage is important, with your sensors. Very, very different, okay? So using FHIR for digital health data really isn't a quite match. So about 15 years ago, I worked on OpenM Health. It's a nonprofit that I co-founded with Simona Carini. I don't see Simona here. And about, I don't know, maybe about 7, 8 years ago, we were invited by IEEE to become a global standard. Again, because you need standards for companies to use your standard, and so we now are 1752, and we are indeed a global standard. So I want to give you a sense of why this is so important. One is, and these schemas are JSON schemas. We do annotate to standardized medical vocabularies like SNOMED and LOINC and RxNorm. If you don't know about them, that's the whole point. You shouldn't have to know about them as developers, okay? But it's important for us to have semantic clarity about what a piece of data is, okay? Now, I think you can see this here, right? So this data schema, you might not even want to call it that, is blood glucose value 128. So can someone tell me, can someone interpret this for me clinically? What do you think this says? What do you think this data point says? Any ideas? Doesn't mean much. Okay, well, make it up. What do you think it might say? Huh? It's a glucose level of 128. Some alternative interpretations? Pardon? It's just a value. Okay, right, it's just a value. You're probably thinking about it, you don't want to share it, that's okay. But really, it's 128, it's an average fasting blood glucose over a 3-month period. Okay, from January to March of 2025. That's the precision we need in clinical medicine. So we have a family of standards. Next is bringing data together, which is super important. So we need to get your EHR data, we need to get your device data. Some years ago, 5, 6 years ago, JP Pollack and I worked with the Commons Project Foundation to build an Android platform to bring your EHR data and your device data onto your phone. Apple has this. Google wasn't going to do it. We asked Google, they just didn't want to do it, so JP and I went and did it. It is now something that you can get on your Android phone. You know, basically every health system uses it because it uses the FHIR API standards, and you see the partners that are there. Basically, any single health system now you can get your data right now. In about 20 seconds, you can get your EHR onto your phone, either through Common Health on Android or Apple Health on your Apple phone. And we do it under the Common Trust multi-stakeholder governance. Trust is incredibly, incredibly important. You may remember those smart cards that showed that you were vaccinated as you flew, you know, to Europe or whatever. You can show that you were vaccinated. Also, there's a way now for QR codes to show that what your health insurance is. So that technology is also built by the Commons Project Foundation. You can see the technology companies and health systems and even government, New York State, you know, United Airlines was on there, countries were on there. So we already know how to build a governance trust fabric across the world. This is with the Commons Project Foundation. So those two components, those are things that I've worked on for a long, long time, but it didn't add up to something that came together, okay? And it's really exciting to see it come together with Jupiter Health to complete the picture. Everybody here has heard of Jupiter, used Jupiter, probably? Yeah, right. It is one of the 10 top codes that transform science. It was created by Fernando Perez here at Berkeley, used by millions of users, tens of thousands of organizations on a daily basis. Indispensable scientific platform for entire scientific disciplines, right? Climate and earth sciences, astronomy, astrophysics, they're all on Jupiter. They're all on Jupiter, and you know what? Nobody's heard about it in healthcare. Like, what? Is it with a Y? And despite that, you know, Jupiter has been implemented. All the major cloud providers use it, of course. Companies use it behind their firewalls. There are companies like Anaconda that support Jupiter-based academic projects transitioning into commercial success. There's a huge ecosystem already around a scientific computing platform like Jupiter, okay? And yet, again, we don't use it in healthcare, haven't heard about it, and you know, in a sense, I talked to Fernando, and he said, well, I don't know anything about healthcare. So Fernando and I got together, and we made Jupiter Health. And so that is what's going to get us from the 1,000 flowers blooming to these individualized bouquets, okay? You can think about it as Jupiter Health enabling sort of florists at scale. Maybe that's one way to think about it. But it's an open source modular platform, right, that brings in the wearable devices, the EHR data, in a unified, secure, AI-powered ecosystem that cuts across all of the problem spaces, okay? So I'm just going to quickly go through the sort of the Jupyter structure. Can come talk to me after. We talked about data standards. Computation is just usually, it's just Jupyter Hub. Tools, we're building them more and more. And then community, we're going to be launching at JupyterCon in November. The way we think about it is Jupyter Health is the horizontal along the bottom. There's data ingestion, there's data standardization using OpenM Health, there's data storage in Firestores, there's authentication, of course, standard technologies like OAuth, management and analysis, digital biomarkers and so forth, presentation tools from Jupyter that many of you use, voila, and so forth, and then an EHR interface piece, which I'll talk about in a little bit. And then vertically on that are early adopters, UCSF. We're having projects built on with hypertension and diabetes. A commercial company called Knit Health out of Berkeley is working on it as well, at Columbia and Weill Cornell. Multiple sectors, and then they can start tying together because they share a common horizontal, okay? So we're very early in this. I think I'm going to skip this slide, only to say that really the conceptualization here is DevOps, that Jupyter Health is a development environment where you've built in the ability to ingest data securely and privately from individuals in real time, both your patient-generated data and your EHR data, that it comes in, you can use like Jupyter AI and all the tools that are part of Jupyter. It can serve researchers and analysts to build your models. And then you can throw it over to Transom, either for consumer health into the patient space and also into the health system space. And there what we're doing is we're using Smart on Fire so that you can port over a Dockerized solution and expand it in an EHR. All of these standards are national. So we're really piggybacking on established standards that allow us to do really a DevOps platform that shortens the development cycle by a lot. I mean, we can do a implementation within a health system on the order of weeks, whereas before it took months and months just to do one cycle of iteration, okay? So what sets Jupyter Health really apart is interoperability across ecosystems. It's open source. Really, that's where we need to go. It's a place for academics and the commercial world to come together, so it's a backbone for these composable vertical solutions. And of course, because it is open source, transparency and reproducibility, at least the infrastructure for that. Where is Jupyter Health right now? We completed a pre-beta demo with 2 devices that we've integrated. One is a incredibly cool technology where you can find out your blood pressure looking at your phone or over Zoom. And it's a company called CareX. It actually works really well. We're in the process of testing this out at UCSF. So we can bring blood pressure data in from just somebody looking at their phone, so no cuff or anything, and also the Dexcom G7. And we're able to bring that data in through Jupyter Health, standardized to OpenM Health, visualized, and then deployed in a Smart on Fire EHR visualization in a sandbox. So with our pre-launch, we had a very successful summit at the end of April. We will be launching at JupyterCon in November. We're just starting our partnerships. Super excited about the possibilities for Jupyter Health. I do want to thank our team because it is an amazing team. So it's Fernando and I who are our co-leads of Jupyter Health. We have Miriam Verith, our managing director, who's right here as well. Simona and I have worked forever and ever thinking about digital health and what that really means in the context of patients and how they use their data. JP, I've worked on, this is even a global way of thinking about trust, so important. Digital public infrastructure that provides trusted open platforms that give us what we need in health, but also support commercial innovation, because that's really what's needed as well. And then also, of course, Jessalyn Dunn, who I've worked with for many years on digital biomarkers and is part of the computational pipeline within Jupiter Health to support us as we go forward. So, in summary, health is co-produced, right? Patients are the core producer. Healthcare systems and community and public health are also important. Most Americans have more than one chronic disease. As we get older, sicker, that's gonna be more important. And the mix of conditions we have will change and wax and wane over time. That's the problem we need to solve for. That's really the problem. AI solutions, therefore, must be composable and individualized. If that's what we really want to get to precision health, it really must be composable. And yet, the way that we're doing it right now, I would say, is not going to get us where we want to go. And have tremendous hopes and expectations for Jupiter Health to be that transformative open source layer to get us to AI-enabled precision health. So thank you very much for your attention.
All right, thank you, Ida, for a wonderful talk. This was super insightful. I have one question I'll start out with, and we'll model introducing myself. I'm Jessie Lynn Dunn. I'm an assistant professor at Duke and co-program organizer of this meeting. And the question that I have for Ida is about the EPIC cons and clinician burnout. And one of the things that we talk a lot about is the multiple different stakeholders. And a lot of clinicians blame sort of EPIC and the EPIC model for this burnout issue. Can you speak a little bit to how you feel that Jupiter Health might be able to address that?
That's an interesting question. So the way I think about EPIC, the electronic health record, really it's two conceptual components. One is the EHR is a database, and it's a database both of the clinical data from patients. It's also a database of clinician actions, right? Orders, transfers, procedures that have happened on patients. So the EHR is really important as a database. The EHR is also a workflow system. And really, fundamentally, that's what it is for us, is a workflow system. And it is a workflow system upon which we have based our entire workflow, the entire workflow. And that's how we build. That's how we do our governance. That's how we do our oversight. We have invested billions of dollars in EPIC as the workflow engine for all of UCSF, and that is true for all the institutions that are using, whether it's Cerner or EPIC. So I think Jupiter Health is not going to get into that, because that is an operational tool. But what Smart on Fire allows us to do, and this is an API for introducing external applications, essentially. And there are other tools, CDS hooks and whatever. But really, these federal standards allow us to, in my view of thinking, turn the EHR inside out, turn that workflow system inside out so that we can kind of hook things into it. That can be composed within the workflow that an institution has to control, because that's how they get built and that's how we run the world. Okay, so this comes back to the real world thing. You've got to understand how the real world works. If you want to go up against EPIC and change that, it's just not going to work. I mean, I thought about it, but that's not my strategy. My strategy is to turn EHRs inside out, use the hooks to get stuff in, and allow that innovation to happen outside of it in Jupiter Health in an open way that's also very friendly to commercial innovation as well. So we'll see where that goes. Other questions?
Other questions?
Hello, my name is Octavia Chora. I'm a PhD student at the LMU Munich in Germany. Thank you for your talk. It was very, very inspiring to also see the new perspective on the other type of data, on the patient-generated data. And I wanted to ask a question related to this kind of data, because as a computer scientist working with EHR data, we already talked yesterday about all the challenges we have to face when the data is heterogeneous, inconsistent, noisy, and so on and so forth. I was wondering, to what extent do you think this patient-generated data, this new dimension, adds really information that we can use for training our models? Because it adds more like variables, right? And it makes the tables of data more wide than they're long. So I'm wondering if this is really useful for models, or is it more like a challenge, bringing in overfitting and all the other?
Absolutely, absolutely, it's both. For me as a primary care doc, I really want to know how my patients are doing when they're not touching the health system. I'm basically flying blind to how they're doing. And so I think patient-generated is super important. It's just a whole category of data. So as you call it, the columns, right? It really expands the columns. They absolutely need that. Oh my God, is it rich, okay? So huge opportunity. Tremendous challenge. Number one, because the data is not standardized. That's why we have OpenM Health. That's why we're trying to do it, trying to start that ecosystem to get the data standardized. And the other challenge is that because it's so fragmented, there's so many new companies, and you've got Garmin, you've got Aura, you've got Google, you've got all these companies. It's not settled yet, and all that data is captured by different companies, right, that own that data in clouds all over the place. And so we don't have a corpus of data that is well calibrated and well documented for us to do our training. So we're actually hoping that will happen with Jupyter Health, because then you can get all that data in through Common Health, standardized to OpenM Health, and that way we can start building that public resource so we can do the kind of training that you're asking for. So that's in the vision. Yeah. Andrea.
Okay. Hi.
Hi.
Nice to see you, Ida.
Nice to see you again.
I am really excited from the patient perspective to see this. My name is Andrea Downing. I am co-founder and board president of a patient-led organization called the Light Collective. You'll be hearing more from me tomorrow. And my question for you is, 100%, I absolutely agree that patients co-create the future. If you were to think about early partnerships and how that might develop over the next 3 to 5 years, what do you see as the role of patient communities in working with this public open source infrastructure, and how?
Great question. Great question. Several answers to that. I think in that diagram of AI-enabled consumer-facing care, and I probably shouldn't use consumer, people-facing. Yeah, we're not consumers, we're just people. And also public and community health. I think that came up in an earlier discussion as well, right? You really do need patients in the room to co-create the solutions and to define the problems. I think initially, the way we're thinking about it is Jupyter Health as the middleware. We're focusing initially on the computational infrastructure. And there we are initially working probably with the sort of the quantified selfers, the people who really get into the data, because we want to understand what do people want to do with their data if they could have it. Okay, so that's one community, but it's a very small subset of people. Columbia, we've been working with Columbia University. They really want to have a layer on top of Jupyter Health that builds in reusable tools to reach out to patients. So it's visualization, it's multi-language. It's really a whole area that I think we've just been starting to think about. So we should connect because I think there's huge opportunity, and we definitely do want to see that. Yeah. I'm not sure it's on. I don't think it's on.
Hi, thank you so much. Okay, better now. For your presentation, I'm Geetika. I conduct research at UC Berkeley. My question for you was, what are your thoughts on building interpretability of patient-generated data? So I've heard from multiple doctors that if they only have 20 minutes, how would they interpret this patient-generated data, right? People could also have like a false positive. They think that, hey, one of my biomarkers from function health report is off. It's panic, or my Aura ring says that this is off with me, and you're bringing all of that information to the doctor, right? And then in that 20 minutes, you have to interpret that, settle down their panic, et cetera, as well. And on the other hand, if we put AI there, and AI is doing that work, the back-end work for the doctor, and actually interpreting this result and then showing you, okay, this is what it thinks that the synthesis is, in that case, AI is actually doing a lot of the decision-making, right? So there could be a bias in the information that it is providing to the provider, right? Because you're not now looking at the raw data, you're actually looking at a synthesized version of that. So wondering what your thoughts are.
Yeah, I think AI is going to be a partner, and so we have a paper under review right now where, we used to have the doctor and the patient, and patient's family, people who are in the room with me in the clinic. Soon there is going to be AI as the third entity in the room, brings its own biases, brings its own power. I don't know that we know how to work with AI yet clinically. I think that's why all of you are here in this room. It's not just a matter of AI, it's a matter of clinical interpretation as well. So, let's just take AI out of the equation. Continuous glucose monitors, you guys heard about that? The thing you stick on your arm and it gets your blood glucose every 5 minutes, really getting a lot of traction right now in, the Make America Healthy Again people. As a primary care doc, I have no idea what to do with CGM data. I really don't. So we're actually partnering with Sunil Kolawad, who's the director of endocrine at UCSF. Their clinicians do use CGM data. The CGM data comes in the way that Dexcom does it or Abbott does it. Actually, now I get Abbott data now, like 2 weeks ago. I can access it in my EHR or something like that, I don't know. But I haven't used it yet because I'm not clinically trained to do that. I don't know what the clinical markers are that drive my clinical action. So we're partnering with endocrine, and they have, biomarkers that are different. It's not your average. It's, the area under the curve 2 hours after your main meal, right? Well, that's just your glucose. You got to factor in your activity levels. You got to factor in your sleep levels. So all that kind of analysis is super, super important that we're not there yet. And actually, that's what Jesslyn and we're going to work on. It was going to have a library of initial models and algorithms where we can start to prototype these things, bring in clinicians, bring in patients. What do doctors need out of this data? What do patients need out of this data to guide their own exercise or eating? So I think it's a wide open frontier. We cannot say, oh, we get all this data and feed it to clinicians. No, that absolutely doesn't work, right? And as you see here, I have patients who have a huge number of diseases, and yet I spend my 20 minutes talking to them about how their husband's doing or where they're going to go to assisted living. So data is only useful to the extent that it fits within a context. So we have a tremendous amount of processing to do that. AI is just a small part of it. There's a lot of clinical science that needs to be done too.
All right. Thank you so much, Ida. This was fantastic. I know that there are more questions, but unfortunately we have to wrap so that we can go to what's on deck, which is the poster session. So that's in the back of the room here. I was asked to announce that if you are a doctoral symposium presenter. This is not the time for that. This is the accepted papers posters. So please make sure you have the correct poster up. If not, we have limited boards. The poster session goes through, it will be open through 1 p.m., but lunch is going to be available starting at 12:10. After lunch, we'll come back at 1 o'clock, where we will hear our next keynote speaker, Guillermo Sapiro, at 1:10. So that is what's on deck. If you have any questions, you can come find any of the organizers at the front or see the schedule online. Thank you again, Ida, for a wonderful talk. Introduced Guillermo Sapiro. Dr. Sapiro was once at Duke, and we recently had a big loss to Princeton by having Guillermo move. He is an Augustine Family Professor in Electrical and Computer Engineering at Princeton. He's also a distinguished engineer with Apple, where he leads a team on health AI. Dr. Sapiro works on theory and applications in computer vision, computer graphics, medical imaging, image analysis, and machine learning. He has authored and co-authored over 500 papers in these areas and has written a book published by Cambridge University Press in January 2001. Dr. Sapiro received several awards, including the Presidential Early Career Award for Scientists and Engineers, the Picasso in 1998, the National Science Foundation Career Award in 1999, and the National Security Science and Engineering Faculty Fellowship in 2010. He received the Test of Time Award at ICCV in 2011 and at ICML in 2019. Dr. Sapiro was the founding editor-in-chief of the SYMPOSIUM Journal on Imaging Sciences. So with that, thrilled to turn over the mic to Dr. Sapiro. Thank you.
Thanks a lot for having me. This is the first time I'm at this conference, but it brings a lot of nostalgia. And since I'm going to be talking about age, I'm going to explain. This is what computer vision and machine learning conferences used to be, this size. And that was a lot of fun. I always explain to my students, for ICLR, we flew to Utah, and there was a snowstorm, so we reorganized the conference in real time in a different location because we all met at the airport, and we all made a decision, let's just go to this hotel and run the conference. And they pick up the phone, and they find enough rooms in an hotel, and we run ICLR. And this is the fun of conferences. I don't go to 10,000 people conferences anymore. They're not fun. This is the fun. So thanks for coming. I'm going to tell you another difference. So the previous part was to make you proud. This might shame you a bit. We didn't used to open our laptops during those conferences. We used to pay attention to the presenter and have an open discussion. Okay? So if you don't want to open your laptop and have 40 minutes of fun, please do so. I'm not shaming you. I do the same. If I were sitting there, I might be doing the same. But those were the big differences that we had enjoying the interaction. So again, thanks for inviting me. As I say, I recently moved from Duke to Princeton, and I also have an appointment with Apple. And I'm going to be talking about age. The presentation before me talked about all the data that we can collect about humans, and I support that medicine should not be done in the hospital, it should be done on our daily lives. But if I were to go to the other extreme, and I will ask every doctor in the planet that you only can collect one number to do all your medicine with the patient that is about to come. You have no clue why is this patient entering, nothing, and you're allowed to collect only one number. Who are the clinicians in the room? What's that number? Age. Age is the stronger, and that's why our entire medical system is based on age. You get a mammography at this age. You get a colonoscopy at this age. You get a calcium imaging of your heart at this age. So that's what everything is based. We like it or not, it's a good predictor. If you're 120, you have way more chances of being dead tomorrow than if you're 20. It's just a matter of fact, okay? If you're 120, you have a very big chance that you are carrying prostate cancer. Just matter of fact. The challenge is that they're all using chronological age. They're not paying attention on what your biology is saying. And we all know very senior people that look extremely young and very young people that look extremely old. So that's what this talk is about. And this is a strong collaboration with a bunch of people, some in my team, some in other teams at Apple. And the basic idea is there is a strong correlation between age and disease. And as I say, we are all using in our medical system chronological age. We like it or not, it's basically an intersection between economics and biology, why you get a colonoscopy at 50 and not at 47. But that's topic for another discussion. So there is a lot of work on age, and there is a lot of interest on biomarkers of age. As I said before, the standard biomarker is your chronological age, when were you born. But there's many other biomarkers that the community is basically trying to understand, to better understand the age of your body. And I'm gonna be very non-scientific when I talk about age, and we can discuss, there is brain age, there is multiple ages in our body, and we can discuss, but there is a lot of biomarkers. There is competitions right now on who has the best biomarker for age. And then there is a lot of basically good science. Once I discovered that there are certain biomarkers that are well correlated to disease, associated, not necessarily causality, but association with disease, then how do I make you to improve those biomarkers? So tons of science. And if you do something impactful, it makes it to the New York Times. It's a very hot area of research. And before I tell you what we did, I just want to make a clarification. When I talk about age, there is kind of two groups in the planet. There is the groups that are very interested in biomarkers of aging and how to improve those biomarkers to give you a healthy lifespan. And that's very different than a group of people, which shall not be named, that their goal is to live longer. And that's a very different target. And many of those want to live longer because they believe that we really need them. And they are basically, without them, the planet will collapse. And some news, the planet is collapsing even with them. So I don't know how they believe. But anyway, I'm not talking about that group. I'm talking about our interest on biomarkers is how do I make sure that you live until the last day of your life a very healthy life, as healthy as possible and as enjoyable as possible. So if you want to reopen your laptop in 30 seconds, I'm going to tell you the message, and then I'm going to tell you the tools and a bit more of results. Most of the studies today on biological age or age clock and biomarkers are based on blood tests or saliva tests. Also brain imaging and other, but it's very common. There are companies today that you can send not a small amount of money over the mail, and they will send you, you send over the email, they send you a kit, you take some blood from your finger. Again, I'm gonna applaud the doctors. I learned how hard it is to take blood from your finger. When I did that, it's actually not so easy. You go to the clinic, the nurses does it in 1 second. It's actually not so easy to get enough blood from a finger, but they send you down, you send back, and they give you a biological age. And it's a really great experience. If you have $300 to $1,000 to spend, I encourage you to do it. We want to do it only with wearables, in particular with the PPG, which I'm going to mention in a second for those that are not familiar. But those that have wearables, is that light green, red, or infrared that you see? I'm wearing an Aura and an Apple Watch. Both of them have PPG. Every reasonable wearable has a PPG. And the idea is, can we measure biological age or an age clock and its association with disease just from wearables? No blood test, no saliva test, no brain scan. The price of a wearable is the same as the price of one scan, but I will be able to do it forever. I wouldn't be here if the answer was not yes. We can. We can extremely accurate, in some metrics as accurate as blood tests. And it's also consistent. And I'm going to show you that it has very strong association with a number of diseases, in particular with cardiometabolic diseases, because we're measuring, a PPG is related to blood flow. Okay? So that's what I'm going to show you in a second with very simple machine learning and very simple statistics. For those that are not familiar with what the PPG is, it's basically you send light through the skin, basically. So there is lights behind this, there are lights here. I cannot control when the green goes on, otherwise I will show you and you will see a green light. But if you wear an Aura or you wear the watch, your partner might be saying in the middle of the night, can you turn off the light? Because you see the green lights or the red lights coming out, very mild, or infrared light. And you basically measure the return. And basically, so imagine your vessels are basically a tube. Blood is flowing. When the blood flows, it just gets larger. When the blood stops, it basically gets thinner. So imagine you're sending a pulse, and you're seeing the periodicity that I'm showing on the screen. That is how you measure heart rate. That's how you measure heart rate variability. That's a basic idea. But there is much more in the entire shape of the waveform. And we're going to try to extract information about your biology just from that, and your biology age, how good or how bad you're aging. So that's a basic signal. How are we going to do that? In this particular case, we're using data from an open study that runs in the United States. It's actually just ended. It ran for about 4 or 5 years, which is called the Apple Heart and Movement Study, where every person, modulo one state, I forgot which state, that they cannot do it. Every person that gets an Apple Watch, when you install it, say, hey, do you want to participate, anonymous, and all that in the Apple Heart and Movement Study? And there is about 200,000 participants in that study, and some of them we have data for about 4 or 5 years. So PPG for about 4 or 5 years, this continuous signal, several times a day for 4 or 5 years. And we are going to basically use that signal. No blood test, no anything. When you participate in that study, we also ask about 25 questions about your general health. Do you smoke? We ask your age. Do you smoke? Do you have diabetes? Have you been diagnosed with diabetes? Do you have any cardiac conditions? So we're going to use that. Now, I'm taking this continuous time signal, and I'm going to learn a representation of that signal. For that, I'm going to be using standard tools. This was also in this particular case, but there are other tools, standard tools from self-supervised learning. Very basic idea. I have data for these 200,000 participants. I'm going to take 30-second segments. By the way, we only use participants that we have about 30 days of data, just to be more robust. I get 30-second segments from participant A. I'm going to say, I want to learn a representation, a 512-dimensional vector, such that in that representation space, every time I take segments from the same person, the representations are very close to each other. Every time I take segments from different people, the representations are far from each other. Standard contrastive learning or self-supervised learning. So I just learned a representation. Every person now in my database is a 512-dimensional vector of PPG. Okay? That's how we start. Then we go to the system, and we say, I need a baseline. So I'm going to look from these 200,000 participants, all the participants that look healthy. They answered no to everything I asked them. No smokers. They haven't been diagnosed with diabetes. They haven't had any heart condition, no hypertension, no nothing. It's about 10,000 of them. And I'm going to grab, basically, their representation I learned just for those 10,000. And I'm going to learn a chronological age predictor from those 10,000, from this 12-dimensional vector. I'm going to just learn a linear projection, basically a linear multiplication is a projection. I'm going to just do a linear application. I'm going to try to predict their chronological age. Okay? That will be the baseline for me. Because from now on, what I'm going to investigate is what's called the age gap. Compared to healthy people in your age range, how older or how younger is your PPG? Okay? So that's my baseline. My baseline is I'm comparing you to healthy people from your age. And I'm going to look at what we call the PPG age gap. That's pretty standard in the literature. So you predict chronological age, and then you look at the difference. So new subjects come in. I'm going to get their representation, and I'm going to compute their chronological age. I'm going to look at the gap. I'm going to look how it changes in time and try to infer some health conditions. So that is the entire method. I learn a representation of your PPG. Every person has one, 512. Then I learn how to predict your age from healthy people, and then I compare your prediction. Okay? So that is the basic method. Let's just see what happens there. I'm going to give you a sample of results. The paper has more results than I can spend an entire day presenting. The first thing that we will ask ourselves is, are we able, from PPG, to predict your chronological age? That sounds kind of crazy. Okay, so I just measure with light. I just threw light at you, measure the return, and I'm going to try to predict your age. Turns out that for the healthy, remember, the PPG representation was trained on everybody, but the age predictor was trained on the healthy people. For them, we have an error of 2.43 years on average. The competition on biological age just came out about a year ago. The result was 2.5 something, and that's from blood. Okay? If I go now around the room, if I pick on any of you, and I say, guess the age of here, you guys are going to be way, way, way wrong. Much more than 2.5. Way more. So it's pretty strong. For those, ECG has an error about 7, just to give an idea of another biomarker. When we take the entire population, because they're out of distribution, I didn't train on them, their error is also not so bad. It's 3.2. Still better than almost anything out there. Just next time, go to the, by the way, just as a side, age is, it looks like, anybody knows how good we are at recognizing faces? Not age, just faces. People that you have never met in your life, and I show you 2 pictures, and you have to say if it's the same person or not. 6 out of 10, we get it right. We're pretty bad even at recognizing people, and I can explain why we believe that we're very good, but we're very bad. And we're really bad at recognizing age. So this is pretty good. The best part is because I have this very, very large data set, I actually can look at fairness and demographics, and I can almost split in, basically a self-declared gender, male or female, age groups, ethnicity. In all of them, we do pretty good. One of the groups that we do the worst is very old people, because it's very hard to get healthy 85 years old. So in our training data, we have almost no healthy 85 years old that have no disease. So some of the error is there. But even the worst groups were doing pretty good. So, okay, my job was from this signal, not just to get heart rate, but to recognize. By the way, you can recognize gender also from the PPG. You can recognize a lot of things. And I'm going to show you even more in a second. Okay, I can do age. But my goal was not to do an age predictor. My goal was to understand health. Before I do that, somebody might say, let me just go back 1 second to my PPG. Somebody might say, why do you need the entire, sorry, I went too much. Why don't just you take the periodicity, the heart rate, or the heart rate variability? It turns out that heart rate and heart rate variability are also relatively good age predictors, but not as good. Sorry, I should have told you that instead of going all this, but okay, one more. We're almost there. Okay, the full waveform, this 512-dimensional space, again, for the healthy is in the 2.5. The heart rate or heart rate variability is in about 7 years. Also not very bad. So now, when you read papers that says that heart rate as a signal is private, please reject them, because it's not. It's not. By the way, every human have a different heart rate waveform, okay? So I can be that entire people recognition person from heart rate. But at least I can infer basically their age, plus minus 7, okay? Not as good as PPG, but pretty good regardless. So we have these people that answer questions. So let's just go and look at their heart disease, for example. And remember, today the clinical system says, you're 60, you do this scan. You're 50, you do this scan. I'm going to say, okay, what is that based? That's based on age-related prevalence. I'm going to do a biological age-related prevalence. So I'm going to take all these 200,000 people, minus the ones I train on, and I'm going to basically say, what's your age gap? And I'm going to split the age gap in quartiles. Those that have a very negative age gap to those that have a maximal age gap. And I'm going to look at the population and say, how often this population has a heart disease. So for example, let's just look at the 55 to 65. The gray line is what, if you go to the CDC, will tell you, based on chronological age. But look, for example, in the 55 to 65, the blue, those are people that have a significant negative biological age. So their body looks younger than their chronological age by about 5 or 6 years. And it's way below what the CDC. So these people I shouldn't be sending for tests at all, because they actually look like 45 there. On the other hand, the red ones, they look very old. They actually look like 65. Their prevalence is like 65, so I should be sending them already to tests that are appropriate to 65 years old, not to 55. And just to give you the relative, so that was the absolute, this is the relative. So the red, again, goes, if you have basically a biological age, which is about 5 or 6 years older than your chronological age, depending what's your chronological age, your rate of heart disease is between 1.5 and 2.5 years higher than it was before. Of course, very old people, everything starts to converge. If you are actually on a very negative biological age, depending on how much you bribe me, I will tell you what's my biological age. I did multiple tests, and I don't know if they talk with each other, but they all came with about the same results. So I started to believe in them. So if you are really good in biological age, basically your prevalence is way lower. We did the same for diabetes. Let me just go to the, and this in particular, the previous one was for male, this is for female. Again, if you look very old, you are between 1.5 and 2.2 more prevalence. If you look very young, basically you have much less. So this is a way better association with disease than your chronological age. So right away, hospitals should be sending devices or blood tests and base their decisions on this, and not based on decisions on their birth. They're actually wasting a lot of money in doing over-testing or under-testing. So that's kind of an immediate application. You can do also survival curves. There's many curves here, but let's just look at the continuous line. Oh, by the way, something I forgot to mention. Look at the 55 to 65 that look very old. They're actually way older than real chronological age forever. So they will never, if you draw a line, if you go to the red and draw an horizontal line, when it meets the gray line is when the gray line is like at 200. So if you have biological age, let's say 5 or 6 years older, at 55 to 60, your rate of diabetes, your risk for diabetes, is larger than any human being alive. So it's not that, oh, you know, I have this cousin that is 3 years older, so I'm going to look like same risk. No, no, no. They never meet. So it's better to do natural aging than biological aging for certain disease. Prevalence. Again, there's no causality here. And that is reflected basically in these survival curves for age 55 with a very low age gap, so -6, that's the blue one. Basically, the gray one is the one that hospitals use today, the red line, and then you can see a hospital can make a decision. We actually run this for tons of diseases, so I can show you here. This is particular case for 45 to 55. Blue is the very low biological age gap, so very negative. Red is very positive. Some diseases, very clear difference. For some, not. We weren't expecting from the physiology of the PPG to be able to learn about allergies, for example. So this is not surprise, but we did a lot of these graphs for the study. I don't want to go too much into that. You can ask the same question, is this biological age associated with disease? Okay, you convinced me, but should I be doing that or should I be doing something else? Is better than HR and HRV and other things. We're also pretty good at predicting an association with smoking. And this is just, the formula is just to say that we have to do the right statistics to normalize. But if you are, so we actually ask people, have you ever smoked? Do you smoke like one in a while? Have you been an always smoker? And we actually show that the more you smoke and the longer time you smoke, the older you look. So on the left, you see the females, and you see the red line are those that basically are everyday smokers, so their body looks way older. So not surprising, but we can capture that from the PPG. And people that just rarely smoke or never smoke, basically this does not affect their age. We normalize, so it should be across 0, both for males and females. Also with exercise, so the more you exercise, the more negative your biological age will be with respect to chronological age. So here we are reversing. The more you exercise, basically should be on the red, and doesn't affect, we do the same normalization. So it's not only disease, but it's also behavior. Smoking and exercise are reflected. I want to reiterate, I don't know how many more times, there's no causation in this analysis. We're working on that right now. This is association, okay? Maybe you exercise less because you have a cardiac condition or stuff like that, so we're not talking about that. But yes, it's associated with behavior. Once again, privacy. If you go to a hospital and you donate your PPG signal, and the hospital runs my algorithms, and they come that you're a +7, they say, oh, you haven't told me, but I'm suspicious that you're a smoker. Or you have diabetes, or you have one of those things. So be careful with what you mean by privacy. It's also associated with sleep. There is multiple metrics of sleep. I'm here just emphasizing one, which is sleep duration. Everybody knows the better you sleep, actually it is reflected in your biological age. Nobody gets surprised. The thing is that we can measure that. So there is multiple metrics of sleep. Every single one we find that was reflected on biological age. Every single one of them. Now, of course, there's not a lot I can do. If you are not a good sleeper, there are some things I can do, but not everything. Contrary to exercise, I can encourage you to exercise more. The more you use your laptop, no, that's just not. It turns out, as I mentioned, that in this data set, we have some people that have been part of the study for a long time. And we have about 161 users that they reported when they got pregnant, and they're part of the study, and they reported when they deliver. And that's the 0 that you see. So I mentioned to you that I'm using currently 30 days of data. So we went back and we took 30 days, 9 months before, 8 months before, 7 months before, to the day of pregnancy, and a bit follow-up. And this is what happened to their biological age. They got older, faster, so the slope is higher than the normal chronological clock, which is in 9 months, you should be getting older by 9 months. Some of those 161 got older by 3.5 years during the pregnancy. The minimum was 1.5 years. So pregnancy show, again, not causation, pregnancy show in your biological age as computed by PPG. Everybody here that was pregnant and had delivery say, come on, I know, it's a lot of stress in the body, it's a lot of work, you change your diet, you change exercise, you change your sleep, you change everything, okay? Look at the slope at the end. I don't know any pregnant woman that slept well for the last month that I'm aware of. So not surprising, but we can see it. Before you ask me, does it get back? Okay? There's good studies on that. There was a study based on blood that got about the same result, but they follow for like a year, and they show that in about a year and a half, it gets back. But then, how can you control get backs? You have babies. I just told you that sleep affects your biological age. To all the moms in the room, did you have a good sleep after delivery? For how many years? I forgot the last time I slept well. And my kids are 28 and 24. So, you know, we're parents for the rest of our lives, for good and for bad. In my case, it's for good. But it gets better. It gets better for those that are in the middle of that, but we can detect that. That's the virtue of having a device on your wrist or on your finger. You just can't have a continuous measurement. We also show association with different cardiac events. Again, the 0 is when that cardiac event was reported. And for example, if you have coronary artery bypass, look how the biological age is getting older and older until right the moment that you had a bypass, which often are emergency surgeries. So you're getting, now again, might be because many reasons, but some cardiac, we didn't find any association, but some we did find. Okay, so let me summarize. We have designed this technique to compute biological age. We show its association with disease and behavior. We show that it's better than just looking at the wave, the HRV or the heart rate. By the way, for those that are less familiar with HRV, so the heart rate is the heart rate, the heart rate variability is how much it changes. So our beats are not in perfectly 1 per second. And it's a strongly a good signal for many health conditions. So we're glad that we find it more. There is a lot of work in the literature of what are good age biomarkers. And Mokri and his team, some of the top, they came with basically 4 conditions. They say it has to be minimally invasive and reliable. I show you, and these are touching my body, but they're not going inside my body. So it's non-invasive. And they're very reliable because I can compute chronological age as good as any other measurement out there. It's relevant to age. We also show that. It can predict disease. We also show. So 3 out of 4 we're doing. What we don't know yet, and that's why this is in yellow and not in green, is how we'll be affected by interventions. We know pregnancy as an intervention affects, but we don't know much more. What's next? We're interested in studies, but I want to give a message about for machine learning. Machine learning is obsessed to getting it right. And what I just showed you is my entire signal is in getting it wrong. So I'm exploiting the mistakes of machine learning because I learn from a healthy distribution. Machine learning is obsessed to work out of distribution. I'm actually exploiting, you are out of distribution, that means something. I compare my distribution was the healthy people. If you are outside of distribution, I could have trained my edge detector on 200,000 people. Why did I train only on 10,000? Because I want you. I want to detect if you're out of distribution. So from the machine learning perspective, it's kind of a completely different focus on machine learning, saying the fact that you're out, so it's like basically saliency detectors. We are actually happy you're out of distribution if you're negative. But that's what we are after that. So that's what we're trying to do, and I think it might open some new ideas in machine learning. I can tell you also other areas that I think the machine learning community is wrongly obsessed with, but that's for another talk, if you ever invite me again. Thank you. I think there is one question there, and one behind you. But, you can shout, and I can repeat it, or...
Thank you, Guillermo. That was fantastic. Kyle, run a mic over to... Okay. While Kai is running a mic over, I will ask one quick question. In thinking about the PPG signal, the skin properties also play a role, right? So has there been any sort of analysis of if there's anything having to do with like skin compliance?
Yeah, so one of the images I show you have Fitzpatrick, and we're pretty uniform, but that's thanks to the sensor people that they took care. They didn't do it for us. They did it to make sure that the heart rate is correct for all skin colors, to make sure that everything else, AFib detector and all those things are correct. But we do have in one of the figures the Fitzpatrick to do that. Yeah.
What about like skin aging properties? So like stretchier skin or thinner skin?
That is very, very interesting because that's very hard to understand. So hopefully your wavelength is penetrating through the skin properly, and that's handled, again, by great sensor people that say we should make sure that we're penetrating through the skin and we're not affected. But you're affected by a lot of things, how tight you're wearing your watch. And that's why you have a collection of 30 days. And there are also times of the day that your signal is more robust than other times of the day, as all doctors know. Again, I'm going to say something, the doctors will correct me if I'm wrong. If you want to do a checkup, do first thing in the morning, not at the end of the day. That's my recommendation. A lot of things happen during that day that affect almost any vitals that you're going to show to your doctor. So sorry for the doctors. All your appointments are going to be at 7 in the morning from now on. But first of all, the doctor is not late anymore because, as we heard from the previous speaker, they only have 20 minutes. But vitals change during the day, all the time. Yeah, so it's good. We have to make sure we control for that.
Hi, Bill Lacava. Thanks for a really interesting talk. I had a question about the last part. So there's this question of, if your model gets good enough, the errors disappear. I understand you're using you're training on a healthy distribution, so you want to be able to attribute any errors to being out of distribution. How do you go about choosing or figuring out when your model is good enough that the errors are attributable to being out of distribution?
Yeah, so that's a great question. I don't have a great answer. Your question is better than my answer. There are some associations that we expected them to happen. So that's our validation. So if we do not find any correlations with diabetes, we have said, hey, we really overfeed for a healthy population, and we're not detecting something is wrong because there should be a signal there. So there has to be a validation set that basically, equally that people that train for anomaly detection, they have a validation of anomalies to say, oh, I know I'm okay with everything I know. The future anomalies, I have no idea. But at least for the ones I know, I'm okay. So that is, that's kind of the best that I can do.
Thanks.
What a thought-provoking presentation. Thank you.
Thank you.
Just curious, is it going to be offered as an Apple on the Apple Watches? Are you thinking of productionizing your research?
You saw me wearing, because we were talking before, I have an Aura offers it. That's the reason I flag an Aura, because I'm interested in the research. Currently, you get many things you don't get in the Apple Watch as of today at biological age. Yeah, Aura measures something. Aura measures from, this is public information. I don't have any private information. What they report in their website is they're using the PPG to estimate what's called the pulse wave velocity. That's the time it takes, basically, your signals, your blood flow through your body. It's a super important measurement. I'm going to explain you. So basically, lower is better. If basically it's related to flexibility, okay? So if when your heart is pumping blood, it manages to make your arteries very flexible, then everything slows down. If I cannot manage and I'm pushing blood through a very thin tube, it just has to move very fast. So Aura claims that they find a way that's their expansion on the website, from PPG to measure the pulse wave velocity. And from there, they go to biological age. That's what I just share the information that I have. But I have to say, N equal 1, my biological age according to Aura is the same as my biological age according to blood test. Plus minus measurement error. So N equal 1. I know some of the scientists there, so I'm not surprised if they do a good job. But yeah.
Thank you so much. A lot of interesting results. I was wondering if there's a way we can also understand the effect of diet on age, and what is a good way to capture and analyze it?
There is, okay, I'm going to do a shame because of the person that introduced me. One of the best blood tests for biological age came from Duke University, from Avshalom Caspi and Temi Moffitt. That's commercial, and it's a work by a professor at Columbia and people at Duke. And it's based on a very longitudinal study. There is a group that did a twin study, reported about last year. There is others, but this for me was one of the most exciting. They did blood-based. They did the Moffitt-Caspi test. I don't know if they're involved. There's a company that does. I have no idea if they're involved with a company, but it came from their research. They did in the UK, there's tons of data on twin studies and very common twin studies in the UK. And they took, I think it was identical twins, and one went on a vegan diet for 2 months, and the other continued a regular diet. And I'm happy because I eat vegan. In 2 months, they already found basically slowdown in age progression. Statistically significant, I forgot. It wasn't like 10 years, but it was enough to report, and it was just in 2 months. I think it's a very important, it was in Nature something, the paper, very strong paper, probably in Nature Medicine. I don't know what happened after the 2 months. It was a clinical study. I don't know if in 2 months they reached the best that they could. I just don't know. There's also studies on vitamins that improve biological age. Those are normally very long studies. So the effects of the vitamin, you see them in very long time. Association, not causation. Maybe that vitamin make you sleep better, which is great. You know, I don't care why. If you're healthier, just at some point, I don't care about causation for everything. But so there are, again, nutrition and vitamin studies that show. And then the public will decide, is enough for me that change or not? But that's a different question, but they have shown that. Yeah. It's very difficult to isolate covariance on those studies. If you're eating better, you're exercising better. So in this study, they control for all of that, but just 2 months. Yeah.
Over here. Thanks for the great talk.
Oh, sorry.
Thanks for the great talk. I'm curious about your definition of what consists a healthy population. So I saw that it's you don't have any comorbidities, you don't take medication, and you don't smoke. And I feel like that might be slightly constricting as like a definition. And I'm wondering why you picked that.
Because that's the data that we had. Okay. Because we had 25 questions, we report them in the paper. And there is another challenge there that it might be undiagnosed. So you answer no, but actually the answer is yes. That's the beauty of having large data sets. That's noisy labels. Hopefully they didn't affect us too much. But you're absolutely right. By the way, if I want to do this for 75, I should change my definition of healthy, because everybody at 75 has something. Almost everybody at 40 has something. So yes, so it's just the data that we had available, and as a first step, we say, if you answer no to everything, we're assuming that you're healthy. Yeah.
Thank you for the great talk. My name is Shadab Khan.
I'm sorry, I lose.
Yeah, thank you for your talk. My name is Shadab Khan. I work at ADIA lab in Abu Dhabi. Have you considered associations with environmental determinants of health, which can be approximated by looking at self-reported zip codes? And presumably exposure to bad air could be something to look at. You consider smoking as a signal in defining healthy, and someone living in New Delhi classified as healthy is probably going to have a very different risk and profile to someone living in, say, Aspen, Colorado.
Thank for asking that. Very important information. We do not, for privacy reasons, the Upper Heart and Movement Study does not collect geographical information at all. So I don't have that. There are other companies that do collect in their studies. Apple did not collect that data. As a scientist, I would love to have it. As a responsible researchers, I agree that we don't have it. But you're absolutely right, and this goes back to the healthy question. It should be adapted to that population, and putting all of them in a big basket, which is not the right basket. But that's will be, more if I really want to use this for clinical intervention, I should be taking into account. I wish I knew polluted areas, if that has influence or not. I wish I knew for those 161 a bit more about their pregnancy, to see why 3.5 years. Maybe this was a very low-income, stressed family compared to a high-income that just follow a perfect diet during pregnancy, and versus a person that didn't. I just don't have that data, unfortunately. But I agree with you that data should be part of an impactful study. I fully agree, and thanks for asking that question.
All right, we can take two more questions, two final questions. So I see one there.
Hi, is this working? Oh yeah. Hi, thanks for the great talk. So I noticed when you had the graph up of the diseases that it was able to predict very well versus not. Most of the ones in red were like cardiovascular diseases, and then there was some movement diseases in yellow, and then the green was sort of non-related. And I wonder if that's a function of what you were measuring, right, which is this, I guess, this waveform. But with an Apple Watch or something, I guess, are there not other domains that you could measure? So, for example, like movement data is something that could also be collected and added in, and maybe, especially as you get older, that kind of functional data of whether or not you're able to move is a better indicator of your age than, say, something just like your heart rate. And so I wonder if you were considering adding in those sort of additional domains you can sort of passively capture.
Yeah, so great point. Yeah, so for those, it's all related to vascular stiffness and things like that. You're absolutely right. For almost every disease, we try to control for everything else for that, but you're absolutely right. Another thing that for those that have an iPhone that we measure is your walking steadiness. And walking steadiness is an extremely good predictor of your health. So it's a very interesting question because it's a completely different predictor, how they can be put together. It's a great question. That means if you never notice and you have an iPhone, open it and hope your walking steadiness is the asymmetry of your body, you should be at 0. That's good unless you have some physical limitation. But yeah, it's a great question. It's a great question. I think, by the way, let me just comment that all these great questions are showing how important this research is and how difficult it is to control for everything. And then we go into what's called, in the fairness literature, demographics gerrymandering. If you start controlling for everything, you end up with n = 1 in every subgroup, which should be done, but it's harder. But yeah, it's a great point.
Hi, my name is Radhika. I'm a PhD student in the Computational Precision Health program here at UC Berkeley and UCSF. And my question was, this data is really amazing. It's continuous over time. And there seems to be a lot of scope for potential clinical interventions or lifestyle interventions that can, help with reducing the chronological age and creating better health. And I was wondering if you could talk a little bit about how people are thinking of prospective clinical trials in this case where you have continuous data, and what adaptive trials and how to kind of show that these interventions work with devices like the Apple Watch.
Yeah, I'm not an expert on that field. There is multiple, as I mentioned before, on nutrition. There is also a famous person that is investing about $2 million a year, slowing down his aging. There is a competition that people volunteer. They take blood tests every few months, and they basically share what they're doing. So there is a company called Truth Diagnostic. I'm not sponsoring, but in their website, they have, I don't know exactly how, I think people volunteer. They say, this was according to Truth Diagnostic, my age. 6 months ago, I did this, and look how younger I am. So I actually like it because it's kind of crowdsourcing, that people are trying things. Of course, this is very non-scientific. They might not be controlling for many other things, but there is a bunch of studies out there on interventions to do that. Most of them are blood-based interventions because they take time, and some people do it. Some companies give you kind of a subscription, and then you get a blood test every 3 months or something like that. So I agree, but that's not my expertise. But if you just look a bit, just Google it a bit, there's tons there, or you just search it a bit. Yeah.
All right. Let's thank our speaker again.
Hello. My name's Emma Rocheteau. It's my pleasure to introduce the Doctoral Symposium Lightning Talks with you. Alongside Matthew Engelhard, we have been working hard on the Doctoral Symposium so far, and we've been blown away by the quality of the submissions this year. So I'm very excited for the posters, which will happen later on this afternoon. And we've got a mentor scheme as well. So if you are a mentor, you should have received an email earlier with your mentee. And we'd encourage you to go and see your mentee's poster. So without further ado, it's my pleasure to introduce Sean, who is going to speak to us about enhancing robustness, transparency, and global inclusivity for clinical LLM research. So thank you.
Okay, can you guys hear me? Great. Hi, my name is Sean. Thank you so much for this wonderful opportunity. And today I'm gonna give you a data-centric view on why we need these really important things. So quickly, some disclosure of me and my PI. Okay, so today is gonna be a language model tour since I'm a language model guy. So, you know, as all you guys know, that's how we've been doing training. We gather all these data, and, you know, as we've been shown, this has a lot of value. But I'm gonna be kind of like a whistleblower today, so I'm gonna talk to you from the source of the training to evaluation benchmarks, and then to how we can actually scale up to actually push them on OOD stuff. So, for people who know natural language processing well, it's a pretty common thing that people put two nearly identical sentences together into language models to get the logis, which is the probability on predicting the sentences, and it can serve as a proxy way of measuring a model's belief. So we take it a little bit further on this. In our work of cross-care, we want to understand whether the model actually holds true real-world disease prevalence in their parameter knowledge. If not, what's the problem here? So the main source of language model learning is from pre-training corpus, as you all know. Research community have been providing these awesome full open source pre-training corpus and also the models strictly train on them. So we can actually poke around and actually understand the training dynamic better. We did the simplest and the dumbest thing here. We made a big counter, basically, a big dictionary on disease, and we have real prevalence on, and also how often they actually co-occur with demographics that we care about, that we actually have the real stats on. So therefore, we'll have our three measurements here. We have a big counter from pre-training, a language model belief, as we just talked about, from Logis, and a real-world prevalence data upload by CDC every year. And then we compare the ranking. So as you can see, the red line here is actually the model correlation with the real disease prevalence, which is like nearly random. But, and also on the x-axis are the scaling law among the model size. You see that doesn't help. But the green line and the blue line actually hold way more correlations than the real prevalence, which is actually the big counter we actually gathered here. Another figure here showing model, training data, and distribution ranking here. They should be a straight line, but they're far from a straight line, as you can tell. It's not just the problem of the base model. Post-training and alignment strategy make it worse, and it's even more challenging on like multilingual setting. So some quick summarization on this work. So pre-training data and LLM belief do not reflect on the real world. Biases will emerge and from pre-training data and directly go through your model. And model do learn a lot from pre-training, and alignment strategy don't really help this at the moment. We also made a visualization website called crosscare.net. If you want to take a look on all these data, you can guess what's the blue line emerged in 2019. Another wonderful work here at CHIL, taking a data-centric view further, which I highly encourage everyone to check it out. So next, we're going to dive into benchmark, which is a key evaluation. So for every drug in the United States, we have brand name and generic name. After exclusivity periods, all the company can make the same generic compounds, but not name the same name. But brand name is actually what people actually use to refer them all the time. So we did a simple thing here again, which is basically we took all the benchmark that people really care about, all the knowledge recalls, and we basically swap all of them from generic name to brand name, which is actually dominant on the benchmark for simplicities. And we only swap the single compounds and let physicians to check through them again. And the first thing you will ask is, does language model actually can match these terms? So the answer is yes. For model from last year, when they are more than 7 billion parameters, they're nearly perfect at this task. After you answer that, and here's the real performance. Ideally, we want everything to be on the diagonal line. However, model does drop a lot after swapping this simple term. And you can see that the closed model are better in the yellow zone, but it's still not perfect. So two things we might think is happening here caused by that caused this. So the first thing on the top is we actually went through the stem of these questions to some common open source pre-training data, and you find a lot of them in there. And the second thing is the asymmetry on the distribution of the terms. On the bottom, you can see there's way more generic name than brand name in the pre-training corpus. Another fun thing that you can actually stretch this idea further is actually testing the contamination. There's like leaderboards on Hugging Face, basically test all these tests, and you can actually get a lot of like quote-unquote biomedical domain-tuned models. And they're crushing the leaderboard, but after swap, they actually show a way bigger drop than their base model that I actually like fine-tuned on. So you actually do see the problem. So that means the benchmark, they could be useful, but there's a lot of things that we actually need to do more to actually not just overfitting. Last part, I will talk about how to auto-scale them really well. So, this work, we actually had international efforts actually collecting most of the MedQA from other places around the world instead of the United States. And as you can imagine, model actually excel like 90% on MedQA in the US, but actually does way worse on the other countries. And another thing we did is actually looking into like real tasks that model care about during clinical trial. And we want to see whether they actually can do clinical trials, similar working stuff on like deep research. And model does really well, but as the hop go deeper, the model does way worse. Thank you so much. It has been fast. I'm here to take questions. And if you care about any of these work, you can scan the QR code to look at them further.
Thank you so much. We have time for maybe 1 or 2 questions for Sean.
I'm kind of curious what you think about the future of medical LLM benchmarks. So do you think they should be more conversational based, or should they be kind of restricted to like the MCAT style questions where we're just like looking at knowledge retrieval basically?
Yeah, so the question is, what do I think about language model benchmark in the future for medical task? So I think the knowledge recall part is actually pretty, I think it's pretty solid on like if you scale really further. So I think real world task and also conversational base is good, but it's hard to make a reward model, which is the problem. That's why you probably have to build more data. But I would like more utility-based benchmark that's actually can help us to measure the real progress.
Anyone else have a question? All right, I want to move to our next speaker.
It's my pleasure to introduce Aishwarya, who's going to speak about robust reinforcement learning policy evaluation in healthcare. Thank you.
Cool. Well, hi everyone. My name is Aishwarya, and today I'm going to talk about improving RL policy evaluation algorithms using generative AI. So, as we've heard from several of our speakers today, modern healthcare delivery consists of hundreds, if not thousands, of diagnostic and therapeutic decisions, which can often place a lot of strain on healthcare providers. And to address this, to alleviate this, some systems have relied on standardized protocols, but these protocols can be inherently inflexible and not patient-centered. Now, reinforcement learning algorithms, which are used to learn the solutions to sequential decision-making tasks, can be used to learn patient-specific treatment protocols. Some of the earliest approaches built algorithms to improve the administration of routine interventions, and over the years, we've seen these algorithms become more sophisticated, able to handle multiple challenges that are present in healthcare, including partial state observability and unknown reward signals. In fact, the promise of the clinician in the loop paradigm is vast. RL algorithms can drive more adaptive, data-informed care. I mean, imagine a future where treatment decision-making tools can actually help relieve the cognitive burden placed upon clinicians. So, what's actually holding us back from deploying RL in high-stakes settings? Maybe you think an obvious answer is safety. And safety isn't just one thing, it's a collection of things. Maybe we need more conservative reinforcement learning algorithms, or maybe we need hospital-specific algorithms due to dataset distribution shift. But in this talk, I'm going to focus on one key piece of the puzzle, which is how do we evaluate policies before we ever deploy them? So say we learned a reinforcement learning policy and we want to deploy it in some sort of a high-stakes domain, such as a hospital. There are 3 ways to figure out if this policy is any good. The first is to directly deploy it in this hospital. Now, as you can imagine, this is ethically dubious, and this is not something that we want to do. The second is to use an accurate simulator, an accurate patient simulator. But as you might imagine, we don't have access to these accurate patient simulators, and these patient simulators vary depending on patient subgroup, et cetera, et cetera. Another option is to use off-policy evaluation, where we have access to some sort of a historical behavior data set, and we can estimate the value of a new policy using this data set. And the value here is just a number that tells us how good this policy is. Now, typical OPE estimators are limited by the data sets that they have access to. In fact, these data sets are often sparse, imbalanced, and contain only treatment strategies that have been used historically. So for example, we wouldn't be able to evaluate a reinforcement learning policy that uses a new treatment strategy. Now, generative models have the ability to improve dataset coverage. They can be used to generate synthetic patient trajectories or even simulate alternative treatment outcomes had some sort of another action been taken. But as you can imagine, these synthetic samples can be erroneous. Generative models, which are themselves trained on finite sample sizes, can generate samples that don't really reflect the distribution of patients that we expect to see in our data sets. As a result, an OPE estimator that uses these models needs to account for this possible error. So today I'll talk about 3 projects that allow us to use these samples, these synthetic samples, in a rigorous manner. And these projects are called Candor, April, and Perry. So I'll start with Candor. As I mentioned earlier, standard OPE methods suffer when there's limited data set coverage. So what if you could get an auxiliary data set that fills in gaps in some of these in coverage? We call these samples counterfactual annotations because they give us information about the outcome had an alternative action, an action in this case is a treatment, been taken. So in this work that we assume that these samples come from an expert. But then the question is, how do you use these samples within an OPE estimator? We build on prior work and show that when these annotations are used in just the reward model component of a doubly robust estimator, that they are most resilient to possible bias or error in these annotations. And when evaluating these policies on MIMIC4, which is a widely used electronic health records data set, we find that one of our methods performs really well, achieving the lowest RMSE in comparison to all the other baselines. Now, the Candor project assumes that these annotations come from an expert, such as a clinician. But in reality, obtaining such expert annotations is costly and time-consuming. So in this work, we propose a scalable approach to generate counterfactual annotations using large language models. And in particular, this work proposes a prompting strategy that uses information about a patient as represented in their EHR, as well as some sort of a clinical resource, such as UpToDate. Then, given a particular treatment dosage or an action, as well as some domain knowledge from the clinical resource, we ask the LLM to predict a particular clinical feature, which is then used as a component to calculate the counterfactual annotation. And as you may expect, the annotations themselves vary in quality depending on the patient or the LLM or the treatment or even the clinical feature. But we still find that preliminary results suggest that there's enough signal that when we use these annotations within CIS, which is an important sampling-based estimator, they do improve the RMSE of the estimator. And this offers a promising approach for addressing coverage limitations. Now, the prior two works have focused on a point estimate of the policy value, but a point estimate may not communicate the degree of uncertainty of the estimator itself. Suppose we wanted confidence intervals, or even better, conformal prediction intervals that are dependent on the data set that we have access to. So in this work called PERI, we introduce two estimators that leverage synthetically generated patient trajectories. And these trajectories are generated using a variational autoencoder. And using both our offline behavior trajectories and these synthetic patient trajectories, we developed two estimators, CPGen, which calculates conformal prediction intervals over the value of a new policy condition on the start state, and then DRPPI, which calculates confidence intervals. There are several broad areas for future work that I'm interested in, including answering some of these questions, like how can we mitigate the impact of poorly generated samples when we use them within OPE or other reinforcement learning methods, and also can improvements in OPE actually enable deployment of RL algorithms in high-stakes domains such as healthcare. Thank you so much for listening. Please reach out if you'd like to continue chatting about these things, and I'll be at the poster session and happy to take questions now.
Thank you so much, Aishwarya. Does anybody have a question for Aishwarya?
Hi, thank you so much. My name is Nitish. I'm a PhD student at UC Irvine in computer science, and I've also been thinking about synthetic data. So you mentioned in one of your work you generated these counterfactuals for patient trajectories. So the possibilities are endless in counterfactual generation. So I'm wondering what constraints you used and how did you evaluate if the counterfactual trajectories you simulated what metrics did you use for evaluating the simulated trajectories?
Yeah, so I'll just maybe clarify on what the counterfactual generations are. So they're time step specific annotations. So we're not generating full trajectories in this particular project. So in this case, like what we expect is that we have a patient trajectory so far, and at a given time step, we ask what would happen had you received an alternative dosage of this particular drug, and you received some dosage of that drug. And we don't have, of course, we don't have a good way of evaluating counterfactual annotations themselves, but we can evaluate ground truth samples. And what we find is that our predictions from LLMs are generally correlated. They have a decent amount of signal with the ground truth predictions for samples that are in distribution. And then as we go more out of distribution, as in like out of distribution from what patients typically receive, we can hypothesize that there's probably more error in those annotations.
We do have limited time for questions, but a reminder, there's also an opportunity to speak about this work during the poster session later this afternoon. Let's go ahead and move to the last talk.
Thank you, Aishwarya. And it's my pleasure to introduce the final talk by Shashank on spatiotemporal graphs for dynamic prediction of ARDS.
Hey, good afternoon, everyone. My name is Shashank. I'm from University of Arizona, and today I will be talking about dynamic prediction, what's ARDS, and how to apply spatiotemporal graphs to it. So let's get started. So dynamic organ failure is a critical condition in ICU, and organ function can go from stable to critical in minutes and hours. And those early signs are buried inside high-dimensional ICU streams. You can think of 200 features, and high-dimensional means you can have a very high sampling rate, maybe let's say 5 minutes. So that gives you, let's say 2016 or maybe 3,000 time steps, 231 features. And the whole proposition is that if you can detect it timely, then you can make some interventions and improve patient outcomes. So here, for example, let's see this patient is an example of ARDS. They have so initially, once they were into ICU, they first had this event of dynamic or organ failure. Clinicians made an intervention. For some time, the condition was stable. Then again, they had 2 more events of organ failure. So there are 2 questions I want to ask here. Which features were important in the starting of time series that led to this organ failure event? And once, even if some intervention was made, why these 2 more onset of organ failure happened? And ARDS is a good example of modeling dynamic organ failure, because when ARDS happens when there is inflammation and fluid accumulation in lungs, so there is inadequate gaseous transfer. It has a very high mortality rate, and similar to any dynamic organ failure problems, the early signs are subtle and dynamic, and there is a time-sensitive intervention window. And again, if you can detect it early, you can improve the outcomes for those patients. So what we expect from a robust prediction framework? First, it should have a long-range temporal memory, because you are looking at data going from hours to days, or maybe go into weeks. And next is you are looking at feature interaction modeling. I want to know whether any changes in electrolyte, how does it affect ventilation or pH. And the third interesting point which relates to interpretability is if you can find out somehow that, okay, which features led, then you can look into, okay, which features, let's say feature X and Y, were really important for the patient before the onset of ARDS. And how does the prediction framework looks like? So for this, I'm using spatiotemporal graphs. Maybe it's like counterintuitive that time series doesn't have a graph structure, so we need to maybe put it into some graphical structure. So let's look at the model architecture. I start with the time series. It's, again, about 200 features and very high sampling rate and time steps. To learn a graph, we need to first window it. So basically, you can think of each window as a patient state. And going from one window to another window, the patient state is changing from one state to another state. And for each state, we learn a graph. So this is the temporal aspect, that for each state, we have a graph. And in each node refers to the clinical features. And the edges will be learned by the model itself. Those will be the relationships between all the clinical features. And once this is trained, so each graph on each time point or time window covers the spatial aspect. And for graphs changing, going from one time point to another, it aspects the temporal aspects. And that's how we get a dynamic prediction model. So and then we compare it or test this model on standardized data sets, which is HiRED, which is 5 minutes of time steps in the resolution. And since this is an imbalanced classification problem, that most of the times the patient would be out of failure state, but there will be very short windows of failure. And so that's why we are looking at the F1-MCC metric. And the graph model is up at the top here. And so since HiRED is a standardized data set, it provides us benchmarks on, okay, how's the recurrent and attention-based models are doing. And once we have a good model, then I tested this on Mimic4 and EIC CRD. And in summary, about the modeling aspect is that spatiotemporal GNNs are very good for ARDS prediction. But we are not stopping here and looking at interpretability, that, okay, we have a good model, what to do next? So in this model interpretability zoo, you can have inherent model interpretability at attention or have a post-hoc model interpretability, that once the model is trained, what to do with it. And there are approaches which are loaned from other fields, let's say for computer vision, or there are some generalized approaches. But here I'm looking at time series specific approaches, and one of that approach is extremal mask. So how does extremal mask work? So we started with a feature and a time series of features and time steps. We would like to learn a mask of the same shape. We have the model weights frozen, and now we would like to perturb this data and then pass this or do a forward pass of the perturbed data with the same model and just make sure that the outputs are same. And what this eventually will do is that it will suppress all the irrelevant information and only highlight which features were really important for the model to come up with prediction. So let's look at the heat map and the data itself. So let's go back to the first slide and see this patient had 3 events of organ failure. And correspondingly, extremal mass finds out that, there are some features which were highlighted for this patient before the onset of the failure. So, this approach identifies which feature time point pairs are important. But this is just one example. What to do with it? So I'm interested in looking at the time series before the onset of the failure across all the patients. So once I extract all these features, I define this procedure called longest continuous run. What it basically is doing is that above a threshold, it just takes out, which features were important, and then binarize it. And so the whole idea is to make or remove that temporal dimension and make it into like a feature or patient feature matrix. And once I do co-occurrence analysis, I get like, which features are active together or have high attribution scores together. So once I get this co-occurrence matrix, I do a low-vein community detection method and I found out that, there is some electrolyte parameters fluctuations like sodium and potassium levels, which are, I don't want to call it like biomarkers, but there are some indications of, these features may co-occurring together. So electrolyte imbalance with some neurological effects are some of the indicators for preceding ARDS. And these features which you see in circle are the common features across high-red EICU and MIMIC, which tells us that, there might be some neurological respiratory effects which are leading to the ARDS. Yeah, so that's it. Thank you. Questions?
Thank you so much. We have time for one question for Shashank.
Hi. I wanted to ask you, what do you think the specific utility is of forming that graph where you've got the clinical features as the nodes? What is it about that contributes to the improved performance, do you think?
Yeah, so I think some methods just take time, like individual time series as input. But with graph, we can say that since this is a 5-minute sample time series, patient conditions do not change quickly in 5 minutes. So even if we have to club together, then we can think of one window as one patient state. And instead of oversampling or saying, I have 5-minute time series, but I'll just take an average across the 5-minute time series to make it, let's say, 1 hour or 4 hour. So I think this is the better way to go, that instead of oversampling or you can make a window out of it.
And then in terms of when you do the time series analysis, do you do that after you've already represented the patient state within those windows as the graph? And then
yeah, so this window is a hyperparameter that, what's the best way to break the time series? Let's visit like 6 hours or 12 hours, or do you still want to keep like 10 minutes as one window?
Okay. Thank you.
Thank you.
All right, let's have one more round of applause for all 3 of our speakers.
Our esteemed moderator is Dr. Emily Alcensor, who is an assistant professor in biomedical data science and, by courtesy, computer science at Stanford. We're actually in the same department. And her research uses machine learning, natural language processing to augment clinical decision-making. She did she was at Harvard for a long time, though her undergrad was at Stanford. But yeah, she did a postdoc at Brigham and Women's. Her PhD was from the famous Health Science Technology program at Harvard MIT. And she was the general chair for SAIL. And aren't you going to be the general chair for CHIL next year? Yeah. you know, funny story is that she really had to decide between Harvard and Stanford, and we thankfully convinced her to come to Stanford. We've all been the better for it. And I learned that she knows a lot about Rome and Latin, and if you want to make her happy, she really likes cheese. Now everyone else is wondering what I'm going to say about them. You have to think, how well do I know you, right? Next, we have Deb Raji. She is a Mozilla fellow, and this is the part that always gets me. She's a computer science PhD student at the University of California, Berkeley, who is interested on algorithmic auditing and evaluation. The reason I say that's the part that always gets me is that several faculty, including myself, are convinced that she's actually secretly faculty because she's just that famous and has done that much. She's worked closely with the Algorithmic Justice League to highlight bias. She's worked with Google's ethical AI team. She's been a research fellow at Partnership on AI and AI Now Institute. Of course, she's Forbes 30 under 30 and MIT Tech Review 35 under 35. Not surprising. Okay, my favorite thing about Deb is that she got invited. She got invited to this, what was it, like a tech thing at the White House? Biden White House. The Biden White House? Where you went and you told off Elon Musk to his face. The Senate, sorry. She just does too many things. But she told Elon Musk off to his face, and I love her more for it. No, it's the thing that makes me very proud. Okay, I'm out of order here. So next I have Dr. Pranav Rajpakur, who is an associate professor, recently got promoted, very well deserved, of biomedical informatics at Harvard Medical School, and co-founder of A2Z Radiology AI. If you're a venture capitalist or in investing, you should come talk to him because he's brilliant, and he will make you, if I had more money, I would invest in him. He's a Stanford-trained computer scientist. He works on developing AI systems that match physician-level expertise through multimodal clinical data interpretation. He's published a lot of papers in journals like Nature, New England Journal, Nature Medicine. I kind of hooked along for the journey for one of those papers, so I'm very grateful. Over 39,000 citations. They should have just made you full professor. And he's educated 84,000 students through AI in medicine. Also, MIT Tech Review Innovators Under 35, and Forbes 30 Under 30, and Nature Medicine's early career researchers to watch. So many accolades. I'm too old to get any of those, and then that's okay. You're amazing. Oh, I have to. So I dragged a couple people for a walk. I said a short walk to get lunch, which ended up being a mile to go to Cheese Board. And I learned that one time he showed up to what he didn't know was pitching a billionaire in tennis clothes because he wanted to play tennis afterwards. So, all right. So next is Dr. Jenna Lester, who I've known for a long time and has been a partner in crime on many research. She is an associate professor of dermatology at UCSF and founding director of the Skin of Color program. She went to Harvard. She's a graduate of Harvard College. She went to Brown for medical school. She has developed clinical services, curriculum, and research focused on dermatological equity. She's very passionate about teaching. She teaches about healthcare disparities. She has received UCSF's Academy of Medical Educators Teaching Award. She has been on every show that you can imagine. She's been in the New York Times. She's been on NPR more than once. She's been on CNN. She's been on CNBC. She's also on the American Academy's Dermatology's Augmented Intelligence Committee and AI Standards Task Force. And also, I don't know why it's not mentioned her, she's also a TED Fellow, and her TED Talk has been very well viewed, and I actually think your homework tonight is to actually go home and Google Jenna Lester TED Talk and watch it, because it is incredibly important for you to understand the biases that exist in medicine to begin with and how they then translate into AI. And then finally, but certainly not least, Dr. Leo Selly, who is the principal investigator behind everybody's favorite medical information mart for intensive care, also known as MIMIC. All of its lovely children mimic chest x-ray, mimic ED, mimic echo, mimic ECG, which all of us have probably used. More than 100,000 users worldwide, open code base, 10,000 publications in Google Scholar from these data sets. So, I mean, this is like the data set. His group has written 3 open access textbooks. The first has been downloaded close to 2 million times and translated into Mandarin, Spanish, Korean, and Portuguese. They've had online courses. They've had close to 100 health data science events in 29 countries. And just has done amazing work. I think he's kind of like Carmen Sandiego, because I'll like be texting Leo and he's like, oh, sorry, I'm in China right now doing this, or oh, I'm like off doing this, I'm in Europe right now. Like, I literally never know where Leo, and he's been to Everest Base Camp too, he was telling me, right? Which one? Everest Base, didn't you? Oh, no, we went to Bhutan, that's what you were to, sorry. I'm not as smart as the people up here. Anyway, I'll let you guys get to it. Make it spicy.
Thank you, Roxana, I think, for that intro. All right, so we have to keep it spicy. That's what Roxana has charged us with. So the goal of this panel, right, is all about ethics of generative AI in healthcare. You all know at this point, right, that there's a huge deployment of generative AI technologies right now. Ambient documentation has taken off. Over 300 hospitals across the country have started to pilot language models to generate draft responses to patient messages. Epic has on their future list over 100 different generative AI tools coming up embedded within the EHR. There's lots of excitement. The goal of this panel is to try to think about how do we actually develop and deploy these models in a responsible way, and not just talk about the risks, although we will do that, but think about what we as a community can actually do moving forward, to make progress in this space. So with that, again, we're gonna try to keep it exciting. It's afternoon here. I know everyone has that food coma. I also want to say we're going to leave some time at the end for audience Q&A, so keep on brainstorming throughout your questions to try to make them sweat a little bit. All right, so with that, I'm going to start just with a question to all of you to just give us a sense. I know we got the biographies from Roxana, but your background in terms of how that shapes about how you think about ethical AI in this space. Deb, you want to go?
I feel like we're going to spend 20 minutes on intros for this panel. Yeah, I think my interest in sort of the generative AI space, I actually avoided generative AI for a very long time, but even before that, thinking about everything from risk assessments, computer vision systems, and now large language models has been very oriented around like functional safety. So if you are developing a model and you're releasing it into the world, how well does that work, and who does that work for? So those are the types of questions that I ask, and that ended up sort of leading me to think about evaluation a lot, think about independent third-party evaluation or auditing, and that's sort of how I got involved in the policy space as well. So thinking about the regulatory requirements for evaluation and documentation as derivative of this question of what does it mean for the system to work and who does it work for?
For the last 7 or 8 years, I've been interested in how we build AI systems that can have the same performance as doctors. I think of that as what we need to be able to scale access to healthcare. Often, when we think about what is the way in which healthcare should be delivered, a lot of it comes down to language. And so what generative AI does for us is it allows computers to communicate with us in language, with data going into it that might be all sorts of different languages. And I think that enables us to get into a paradigm in which we don't have to shift into the computer's language, but the computer is shifted to our language, and we can keep a lot of our workflows as they have been in the world with humans everywhere, to essentially get one part such that the interface is still English, but the implementation is with intelligent AI.
I think Roxana has mine. So I come at this from kind of the opposite viewpoint from what we've heard so far as a clinician, someone who sees patients every day, including today, and who mostly sees patients who have been harmed by the medical system or who are currently historically excluded. And so therefore I'm always thinking about how to protect the people in front of me, and I'm often swerving out of my lane as a dermatologist to help advocate for them. So that's kind of how I see myself in this realm, and came to this through reading research and conducting research on imbalances in images in dermatology, and so learning about AI and the bias baked into the algorithms from those imbalances, and thinking also just about how our society is unequal and how that data flows. So as a clinician delivering this care, and who will soon be delivering care from generative AI sources, what can I do to protect the patients in front of me? How can I understand the technology that we're using and influence it to make it better?
Okay, I hope you haven't had your coffee because I'm just going to give you a triple espresso. So some people don't know, but I actually worked in New Zealand. And I see us now building a hobbiton within Mordor. So we're trying to come up with ethical framework for AI when we live in Mordor. And what do I mean when we live in Mordor? So one, there is still that very, very strong publisher parish culture where all we want is publications in Nature, in Nijm AI, getting a paper in NeurIPS, in ML4H. And for decades, we know that this is very harmful to science. Second, we are at a low time low. Scientists are not seen well in this society. They don't trust us. So no matter what we do, they will be paranoid, skeptical of what we're doing. And then what else are the other reasons that we are live in Mordor? Health AI is being driven by technocracies right now. We could keep screaming, but we don't have any say in what is invested in. It's really OpenAI, it's Microsoft, it's Google. So that's number three, three reasons why we think we are in Mordor. Number four is, as you know, there's been a cultural shift where the ethos is I before we, me against them. So we've moved more individualist rather than really being after the collective good. And then the elephant in the room is a capitalist narrative that really writes our script. There's corporatization of healthcare, not just in the United States, all over the world. So this is what we're up against. And we could come up with the best framework, but we're still in a bubble. It's not making any dent because we have to address all these elephants in the room if we're going to have any impact. Back to you, Emily.
Thank you for that. So no, I think really Leo set us up here in terms of what is different nowadays, especially with this technology. So I actually want to pose it now, kind of going back this way, starting with Jenna, maybe, what new ethical challenges do you see that have specifically come out of generative AI relative to, predictive models, and, specifically anything that you might be underappreciated by the audience in this room as well?
I would argue that they're not necessarily new. They're maybe superimposed on a new topic, but a lot of these are challenges that have existed. So, talking about testing, Where are these generative models rolled out, and what communities are subject to the lumps and bumps that happen when you're trying to fine-tune something? They're often communities of color, they're often under-resourced communities, and they're often communities who will never experience the benefit once these tools are sort of shored up and we're using them more widely. And I mean, that's true of vaccinations, that's true of HIV medication, that's true of a lot of other innovations that we've had in medicine that we now see as contributing to human health. But so I would say that this is an ethical challenge that's not new, but this is a new sort of shiny device in the room, and that's how we're seeing it superimposed right now. So I would say who's testing it, who's subjected to that, and who actually has access to it when it's rolled out.
I think it's getting very hard to know when to trust a human over the thoughts of the AI. Just over the past few weeks, I'll just give you one experience of mine. So one of my family members ended up in the hospital and was having symptoms that weren't being looked at by an attending. This is in India, very good hospital in Mumbai. And so you'd expect good quality care. So I entered the symptoms into ChatGPT. I have my O3 instance always running. And it came up with a list of suggestions. And then I was able to get the medications list, and it refined the suggestions. And it basically said, this is a drug-induced side effect. And so there was a treatment plan, and my family members were on the other side. I said, hey, there's a treatment plan. I'd like you to share this with the attending physician. And what I did, now being a computer scientist, not being a clinician, but I think I am able to verify to the best of my knowledge, is one, I called my friend who's a doctor. And the second is I ran the same queries through Gemini and through Claude Opus, and all of them gave me the same answers. And that made me feel more confident. My friend wasn't so sure about these changes. So my family took it over to the attending. Attending sort of ignored it and said, no, I think it's fine. I think that's good. Family member got discharged, went home. Another care team at home, same question. They said, this looks reasonable, let's try it. The symptoms side effect went away. It was drug-induced, and the treatment plan worked. And that goes to speak about, I think, some of the ways that we've been thinking about AI as a tool, which can be supporting a clinician in what they do and enable them to do what they do best, I think is being challenged. And maybe that's a good thing. I think often in our minds, we think about smart clinicians. Like if I ever had a dermatology question, my first text is going out to Roxana. Even if it's not a dermatology question, maybe it's going out to Roxana. But the truth is, the average doctor in an average environment, the average clinician, the average time is not what we expect or what we get in the highest quality of care. And it is so important to be able to empower the patient and their family members to be able to have the ability to access intelligence. And what worries me in today's world is anytime a piece of data cannot go into a large language model. Everything that's in text today can go into a large language model. Everything that's an image today doesn't go into a large language model well. And so that's why a lot of my focus on imaging is to be able to solve that problem, the access problem of you should be able to get any kind of medical data into a system that can generate it well. I'll just share one final thought there, which is it doesn't worry me too much the way that these frontier models are trending towards solving some of the problems that are being exposed as a result of academic research. A lot of us on the stage work on bias, on creating benchmarks for bias that become standards that we hold these models against. What worries me are these models that are being created by people who are not frontier models that are going to be way worse at the same set of things that we've worked so hard to optimize these frontier models on. And I think that is going to be a potentially way to make the directionality of these things much worse, and something that I fear will happen in the generative AI world.
So before you move on, I just want to dial into one of the things that Pranav said and get the reaction maybe from the clinicians on that side over there, which is, Pranav, I think you mentioned, right now you're skeptical of, in some ways, doctors who don't use AI right now. I'm curious, what is the threshold right now for what is good enough for us to be able to deploy something? What I often hear as an argument is like, we're holding these models to too high of a standard. We don't want it to be, it doesn't need to be as good as like the best clinician. It needs to only be as good as like the average clinician, or like you can't get primary care nowadays, right? So like something is better than nothing. I guess maybe starting from that end of like any reactions to that comment.
Do you mind if I?
Oh.
No, I was also, I don't know if it's possible to just react, because I think I disagree strongly, I think, with some of what was said, in the sense of like, I think the example that you shared is an incredible example, and I'm really grateful that your family member was able to get care, but I think one of the main differences, and I also agree that there's a lot of the issues with generative AI that is the same in terms of issues we had with risk assessments and computer vision models, but I think that there's a couple of things that are quite distinct that makes that example even more difficult to work with. One is the lack of reliability of these systems. Like, we don't really know what to expect from these models. There are instances in which they might identify issues that a physician does not see, but really, the expectation of them as a knowledge repository is very different from the expectation of them as a summarization tool, which is very different from the expectation of them as a translation tool. And I think especially when I talk to, I'm on the advisory board of a group called the Health AI Partnership, and so I interact with, representatives from different health systems, and they talk about what they think a large language model can do. And I think the expectations people have of these systems is so wide-ranging. It's anchored onto, everything from OpenAI marketing to, rumors they hear from their colleagues as to what the model can do, how the model can parse different documents or answer certain questions. And I think the reality is that, we haven't actually evaluated the model on all these different tasks. We don't really know, in the case of, the example that you shared, if it was a different drug that maybe was not represented in the data that happened to be used in model A versus model B, it might not have been able to identify that problem. We just don't have very rigorous evidence of, the robustness of these models under different, prompt formats and contexts and scenarios. And then we also just don't have kind of a robust claim around, what is the model actually capable of doing? What kinds of questions are they capable of consistently answering? I think when we're interacting with human experts, one, there's a liability structure that ensures that, there's some degree of due diligence, there's some degree of due process, but also two, there's sort of like a consistency to the response that we have no need, there's no evidence that we have that we should expect that degree of consistency and robustness from these models. So putting that out there. And then I think the second point I was gonna make is the way we anthropomorphize these models is actually really problematic. I think because we're interfacing with these models in its natural language and we interact with each other with natural language, I find that when I talk to people about a risk assessment, there's some degree of awareness and understanding of, the risk assessment gives me this type of information. I need to get other types of information from other sources. And the risk assessment is trained on data, and because of the way in which we interface with the outcome of that risk assessment. Whereas with large language models, it interacts with us the way that we interact with humans, and I think people ascribe emotions, they ascribe expertise, they ascribe so many things that they would ascribe to a human to these models, even though this is not a human. And so I think that's another degree of complexity that just opens up a whole can of worms as well.
Okay, I'm gonna call a spade a spade. My take home from your story is one of the biggest problems right now is hubris. So perfect is not the enemy of the good, it's hubris. And unless we can chip away on the power structures, because There all this talk about shared decision-making and patient empowerment when in fact, there's a hierarchy out there. These are the doctors and you are the patient. You are not smarter than me because you did not go to medical school. So to me, moving forward, we really need to dismantle a lot of the systems, the legacy systems that are in place. The system for education, the system for innovation, the system for regulation. We're shoehorning AI into very broken systems. And it's just going to accelerate the crumbling of those systems. So we are being given here an immense opportunity to reimagine the world. We refer to this age as a Promethean age. AI is fire. We are being given fire. And it's up to us whether we burn down the world or we create something beautiful. But that means that we need to rethink how we solve problems, how we learn, how we teach, because the old ways are not going to cut it. So where do we go from here? And I really think that this is a juncture where everyone here is being given a chance to wipe the slate clean and think, what do we really need to do? What do we really want to do? And our call to action out there is to really include philosophers in your group, because it always boils down to what is our definition of progress? AI is going to accelerate progress, but what does progress mean? And more importantly, who gets to decide what is the definition of progress? When we say efficiency, who benefits from that efficiency? So to me, the legacy of AI is allowing us to zoom out because suddenly everyone is interested in the system. And you evaluate the system by looking at the data output, and whatever is not being given in the data output, we start being curious. What is there so that we could complete our understanding of the situation? Because AI is not about coding. AI is not about modeling. AI is about redesigning systems. And I think we will be remiss if we allow AI to actually even reduce our agency and capacity, because there's a strong temptation to be lazier. I think we're a year away when we already have one. We have a model context protocol for Mimic where you could just interact with this MCP and ask it to write a paper on prediction of delirium in the ICU. We're not that far off. That's going to get better and better. In which case, what will be our contribution? Because we are going to be outsourcing all the steps of scientific inquiry. So somehow we need to rethink now, right? A scientific paper should not be introduction, methods, results, discussion, because that could be generated by AI 99% without any human involvement. What we need to rethink is, what should the scientific paper look like so that we are able to preserve and demonstrate human decision-making at every step of the life cycle of your project? But this requires a lot of political will and also a lot of activation energy. And that is the challenge to everyone, right? Stop building models. We're drowning in F models, right? We need to design human AI systems that are humble, that are curious, that are empathetic, that derives pleasure from learning. Because we have completely sucked out the joy from learning by giving us these perverse incentives that you have to have 3 NeurIPS papers to be able to get your PhD. No one is enjoying learning anymore. It's all about ticking the boxes. So here's an opportunity, and maybe we could do this better with AI, but we have to do it with AI in mind because AI is in the air that we breathe.
Jenna, do you have something you want to react to that?
So one thing I wanted to pick up on is what you were saying about who gets to decide, who's in the room. We should have philosophers on our team. I would love if I could just get some audience participation for a second, because I know that I would probably need it if I were out there. How many people in the room are computer scientists? All right, and then how many people in the room are clinicians seeing patients in medicine? Okay, and then how many people would consider themselves a community member or a stakeholder not associated with the university? Okay, so one person. So I think this is illustrative. We have, whenever we're having these conversations, whenever we come to this table, part of what I like to do is figure out who's absent. And I think a glowing absence here are people who don't necessarily have like a professional stake in this. So like Leo was saying earlier, there is a drive to publish. We're benefiting from whether this fails or whether this changes things in the way, this meaning AI in healthcare, changes this in the way we're predicting. But the people who stand to lose from this if we don't get it right are people who are not even in this room. And so I would say that one of the biggest issues that constantly comes to mind for me is that we do not have a collaborative enough structure when we're talking about AI and designing systems. We need, I say regular people, but citizen scientists, people who are not designing these models, who have a stake in it from how they stand to lose from, interactions with their physicians or whoever, or really just missing out on optimal healthcare. And I think, again, from the academic side of it, incorporating people who think differently, philosophers, social scientists, et cetera, like we need to be coming at this from a different vantage point.
Yeah, just to plus one that, I think another thing that I notice, and I'm kind of curious if anyone works with nurses or other operational staff at the hospital outside of physicians. Okay, that's cool. Yeah, I think sometimes when I'm in academic spaces around machine learning for health, there's, of course, not thinking about the patients and the communities that are impacted, but I think also just even within hospital structures, when I talk to and work on machine learning deployment in health systems, physicians are part of the conversation, but a lot of the users are nurses or other operational staff. And so just thinking through what other stakeholders are actually part of this conversation, the California Nurses Association went on strike last May because of the use or misuse of AI in the California health systems. And so, what does it mean that they had no connection to communities like this and no awareness of the research coming out of communities like this? And they're the ones sort of organizing on the ground around how they get to use AI and how AI affects their work, but also their patients. And so just thinking through other stakeholders, I think, is also something that often gets neglected in this conversation.
So how could we incentivize or enable bringing those people to the table?
Oh, you're asking me?
Or yeah, anyone who wants to take that. I'm just thinking of how do we turn this into what people can take away from this and change in their work?
We have to ask. I think it's a very simple ask. We think that people are disengaged or don't know or don't have anything to offer. I think a lot of people are paying attention. Every single room that I walk into, I have a remote human scribe, not an AI scribe, but I walk into the room and say, this is my medical scribe, and every single person, is that AI? And then there's a visible reaction either way, like, oh, it's still a human? Wow, I'm surprised, or please turn that off, I don't trust AI. This is something that people are very clued into, and having had this scribe for 5 years, I see how this has changed, whereas a few years ago, no one really cared either way. So I think there are many more people who are wanting to pull up to this proverbial table and just need to be asked.
Yeah, just on the sort of other stakeholders within the hospital setting, there's a health system I was working with where they had done all this work, they trained the model, they'd gotten internal approval, it was this whole multi-year saga to train this model, and then right at the end, they brought in the chief nurse, and they were like, okay, so here's the model, and here's the training manual we developed for your nurses, and she was like, what? They had just been excluded from the entire development process, and they were just expected to make use of this system. And I think there's, to Leo's point, it's like there's hierarchies in these organizations, there's legacy issues that result in this, but just thinking through all the different stakeholders that are going to be involved and including them as early as possible versus right at the end. In this case, a lot of the nurses refused to use the AI model that they had trained, and worked to develop for years because they just weren't part of designing that system at its beginning. And also, the default organizational workflow that's sort of on the books, on the records, there's a mismatch between that and what the nurses were actually doing. So who knows if it actually necessarily fit into what they needed at a practical level. And so there's all of these questions around when do you include these stakeholders. My kind of bias is that if it's as soon as possible, then you get to the sort of most meaningful intervention down the line. And then sort of to Pranav's story, then at that point, if you sort of include these stakeholders as early as possible, then when you present them with some of these results and you start having a conversation about expectations that you have of these systems, then it feels a little bit less antagonistic. It's a little bit more of a shared conversation where they can share why they have their doubts and why they're leaning towards ignoring something versus accepting a result.
What was I going to say? So my question to the group, including the audience, and I'm hoping to engage you more to think about this, ruminate, marinate on this idea. So how much AI literacy does the patient need to have? I hate this thought that we are the technical experts and they provide feedback, they provide perspectives and lived experiences. And then we continue with this hierarchical asymmetry of knowledge, right? Because it's not going to work. And what we are promoting is that nurses should have some AI literacy, patients should have some AI literacy so that they could engage with us in a level playing field. But the problem is that how do you educate the entire society in a field that is moving so fast, where the classrooms are in Zoom meetings and on Signal and WhatsApp? So again, this requires us to rethink how do we educate. Because as soon as you have a curriculum in health AI, it's already outdated. I teach a course with Margie, and every year we have to completely revamp the curriculum. So again, you tell this to the teachers. Well, you're going to have an evolving curriculum. And they push back because humans are lazy. Like, why do I spend another 20 hours rethinking my curriculum? And we are teaching health AI in high school students in Providence. And we told teachers, we're going to teach it with you. We're going to bring in our graduate students, and they're going to be co-creating notebooks with you. We're going to be asking the high school students to provide feedback. So we just had a datathon for high school students where we actually asked them, how do you reimagine teaching high school history, high school English, high school algebra with AI? Because when we posed that question to the teachers, they couldn't come up with any ideas. So what we're really doing now is bringing in young minds and not necessarily graduate students, because all of you think alike. So I love the saying, if everyone is thinking alike, no one is thinking. Because if someone had been thinking, she or he would have pointed out, hey, we have a lot of blind spots here, because yes, we look diverse, but we all train in the most prestigious institutions. And yes, we might have some different upbringing, but again, somehow we converge. So I think that's the challenge for us now, as I alluded to earlier. How do we reimagine the world so that it is closer to what we envision it? But that requires a whole different set of energy, a whole different set of agency. And the problem now is we don't teach students critical thinking at all, no matter how much you push back. And I get pushed back by leadership in medical education. Of course, we teach doctors critical thinking. Like, no, you don't. You teach them to behave like you. It's almost like AI. We anthropomorphize it. Oh, there's going to be sentient AI. Of course not. Because AI cannot think, cannot feel. It could pretend that it is sentient. And maybe someone was saying that maybe it's not important if it's sentient or not. It's what we think is important of whether we think it is sentient or not. But in reality, they will not be intelligent because it's just a statistical collection of words and patterns that are being detected, that are being spitted out. So I think, again, I'd love to engage with you to come up with some brainstorms of what education might look like, innovation might look like, knowledge creation might look like, scientific inquiry might look like.
Just, I know Emily's like, I've gone through like one question. But I was going to say, like, just like to be very, very practical, because I know there's a lot of computer scientists in the room as well. I completely agree that like education, training, and sort of kind of informal participatory approaches in the design and development of these models is like, you know, things that has been floating in the air for a long time. But I do think that there's some like very specific kind of like technical infrastructure innovations that's been very interesting to explore, to think about. A couple just to like, you know, shout out stuff happening at Berkeley, like UCSF has this sort of impact, online monitoring feedback system, kind of incident database monitoring, adverse events reporting type system for the AI Scribe deployment. And that's been super interesting just as an approach to collect data as to actual user interactions with these models, but also getting feedback from patients, getting feedback from doctors as they're using these systems. I talk a lot with the Chatbot Arena people where effectively they're soliciting feedback from different users of these models. I think because generative AI is fundamentally unstructured and fundamentally underspecified, benchmarking can only go so far in terms of representing what people actually think the model is going to do and representing people's expectations of the model. And sometimes the only way you can really know if the model did what people expect it to do is by asking them or engaging them in some direct or indirect way. There's a lot of analogies to what we're seeing with respect to the role of feedback for these generative AI systems and the role of feedback for something like social media. And so I think there's a lot of like technical opportunities if people are looking for opportunities to use their computer science knowledge to think through questions around participation, questions around sort of engaging different types of stakeholders. I think there's actually quite a lot of like infrastructure needs in order to enable that future that we imagine where different types of stakeholders can give us feedback and participate in this process of, training models, annotating data, giving feedback on the model performance and evaluation.
So I'm going to ask a bit of a pivot question, but then after that, I will turn it over to the audience. So again, think of your questions. So I know, Deb, you've mentioned a lot evaluation of these sort of models. And I know many of you have done work in this space in terms of how do we best evaluate generative models from hallucinations to downstream deployment to what does it actually mean to construct a good benchmark. So I'd love to hear, I guess, from each of you, what do you think is missing right now in how we are thinking about evaluating these models? Whether that is engaging with different stakeholders, whether that is the level in which we're actually doing this evaluation, whether in terms of like evaluating the base model versus evaluating the fine-tuned model, whether that is like human-in-the-loop evaluation. So maybe, Deb, you want to start? We can go down the line.
I feel like I've been talking consecutively for, so we taught a class on evaluation in the spring semester, and that was a very fun class for many reasons, but I think one of the reasons it was fun was because we approached it very historically, so we looked at the first proceedings of ICML in 1980s, which Stuart Russell was there as a Stanford PhD student. It was really fun. And so we kind of looked at what's the history of evaluation practices in this field, and why are people so anchored to benchmarks, and are the statistical assumptions underlying benchmarking, which is this idea of the holdout method, is that something that applies for stuff like generative AI? I think the whole class and a lot of the work that the students produced convinced me that I think benchmarking was developed under a very specific paradigm, like statistical learning paradigm, where you train you train a model on data that's in distribution, and then you evaluate to see whether it generalizes to more in distribution data, and it's making claims around generalization for that model. And it worked very well for supervised learning and computer vision. And I think when we started moving into 2016 onwards, things started getting really weird. People started creating benchmarks like GLUE, the General Language Understanding Evaluation, and so these benchmark suites and ImageNet, where they started making claims around not just the ability of the model to extrapolate to perform in distribution, but the ability of the model to sort of accomplish a wide range, classify a wide range of labels or execute a wide range of NLP tasks. And I think part of it was because people were noticing that these models were increasingly flexible and increasingly like pragmatically useful across a wide range of things. But I think that's when we sort of lost the plot in terms of evaluation, because we kept relying on these sort of static data benchmarks that are inherently scoped to evaluate something that was increasingly underspecified and unscoped. And so I think like we're kind of in this, a lot of people talk about the evaluation crisis. I think a lot of it is really just holding on to benchmarking when there's actually a lot of other ways that we have tried and we can try to evaluate these models and we should explore. So I'm kind of in my anti-benchmarking phase, I guess, if you want to call it that. Like I'm kind of like, there's so much beyond the static data benchmark that we can explore when it comes to evaluation. Actually, I think Roxana, I'm not sure if you're on this paper, but there's some interesting work in terms of simulation. There's some interesting work in terms of human feedback. Like I mentioned, sort of this aggregated individual reports that we've already started doing in various contexts. So I think there's a lot of things that we can try to explore methodologically that can open things up, but also give us a much more accurate assessment of what the model's going to do in practice, rather than the sort of like static data benchmark norm that we just inherited as like a academic research norm in the machine learning space, from sort of the supervised learning era of the field. So I'll end that there. But I think I have a lot of thoughts about evaluation. I think the second thing I'll say is evaluation is very important because it plugs into various things. So, the reason people like benchmarks is because if you have the highest number on this benchmark, then the VC will give you a lot of money, or people will buy your product. And, we've seen that how benchmark numbers and performance factor into like procurement processes at different institutions. And so I think something else that I've been reflecting on is how does evaluation feed into other processes? Why is it so important to have an accurate assessment of this model? Usually it's because the models are ranked in some way and some decision is being made based off of that. And then regulatorily as well, sometimes there's these expectations we have of these systems. It's not actually appropriate to deploy the system if it doesn't meet a certain standard. How do we set that standard without an evaluation? The AI safety institutes, that kind of thing. And so I think another piece to the evaluation conversation and why it's so important to innovate in the evaluation space is that it feeds into all these other processes. And so that's something that is becoming increasingly clear and makes it increasingly important.
Pranav?
I think what we're measuring on is probably one of the single biggest challenges in medical AI today. One of my postdocs, Xiaomin, works on benchmarking. We released one of the largest data sets of medical images worldwide right now. It's called the Rex Gradient data set. I just want to give you a little bit of backstory on benchmarking and evaluation. So in 2021, when there were basically 3 data sets out in the world that were larger than 1,000 patients for medical imaging, of course, one of them by Leo and group, at the time, we thought, we aren't measuring performance on more than 3 hospitals. How did we end up in this situation? And what would it take to actually make data public from different hospitals in the world? And the idea was, no one's going to give us data. No one's going to make it public. And so we said, here's what we're going to do. And I credit one of the students I was working with, Henrik Markland, with this idea. He said, what if we went to doctors in individual hospitals and said, give us 10 images, just 10. I thought, people are going to think we're crazy, just 10 images. And we ultimately settled on 100, which is we're going to go to physicians in various hospitals, and we're going to say, 100 images shared, we're going to make it public. We're going to make it the largest public data set accumulated from different hospitals. And let's see how this works. And so we sent out a bunch of emails. I must have written about 1,000 emails to people all around the world that published in this field and said, hey, we'd like to put this together. And we had so many people respond back saying, I don't think my institution will ever go for this, but I'm going to try. This was 2021. Today, we have a worldwide network of about 120 hospitals that all have agreements with us to make their data de-identified on site, shared for public release. And some of these have been very interesting in that they're the first examples of partial medical records that have ever been made available from those countries. In fact, our strategy with a lot of these hospitals now looks like the hospital IRB comes back saying, our country doesn't allow this, and we just say, actually, a rival hospital from the same country has already done this. And they go, oh, well, let's check back our records, let's see if we can make it happen. And then lo and behold, 2 months later, it happens. And so what we found in this setting is if we want to measure global performance, we got to collect global data and then make that available for people such as the developers of these systems and see how well it works. And we found, hey, we picked a bunch of models that work well on US data and we applied that, just stopped working. But then we also came up with strategies that allow us to take a very small number of examples from every hospital and create a strategy for learning that allows us to do well at all these hospitals. We're making the first of these data sets available in the upcoming month or two. So it should be an exciting resource for playing around with. But I encourage people to do more of such initiatives because I think that's what's going to move the needle, ultimately us being able to produce these benchmarks.
Jenna? So I guess I'm losing the initial question, which was, what do we think is missing from evaluation?
Exactly, yep.
And I think the lack of a standard, I think, is what comes to mind as a clinician. How do these computer science terms and developer terms like benchmarking, et cetera, how does that translate to clinic? What's the ethical standard that we're dealing with here? What's the definition of a de-identified photo, which is regulated by HIPAA, which is really only has dealt with other forms of data at this point and is executed at the level of the state, so there isn't even a uniform definition. So when you're getting data from other countries, do those patients know that their data is now being used for AI when it was typically captured for clinical monitoring purposes? I think there's just so much swimming around that we don't have a standard for, that we haven't engaged ethicists on, that we haven't engaged people who are involved in this work not because of what's currently happening, but because they've studied it in various settings. So I think that's what makes me a little uncomfortable and makes me wonder how this eventually rolls out and when I'm using it for a patient. And when they ask me a question, can I feel confident about the answer that I'm giving them? So yeah, I would love to see more standards around evaluation developed and around ethics.
So what is not missing in the evaluation frameworks now? First is some people, the lay people, they conflate benchmarking with evaluation, and they're very different. I'm also against global evaluation framework. So we have a paper right now where we're trying to come up with foundational principles of what evaluation framework should be. First is local or even hyper-local. Like, who are we to come up with how to evaluate AI in Bhutan or in the Philippines? They should be the ones coming up with evaluation framework. So the T is task-specific. You cannot have a evaluation framework where it is able to provide some assessment on different tasks. Like, it just doesn't make sense. Like, there has to be a different evaluation for summarization, a different evaluation for mental health counseling. So we are now in the business of organizing real-world evaluation where we invite patients to come in there to tell us what is important for you when it comes to interacting with a chatbot. So it's not up to us again. So it's not a matter of what is missing in the evaluation framework, but who is missing in putting together this evaluation framework. So the A, it has to be agile. Like, you could have an evaluation framework now, but be prepared to pivot a year from now because you've realized your evaluation framework is not providing the evaluation that translates into better patient health outcomes. The R is reflexive and reflective. So again, being paranoid that your evaluation framework now is no longer relevant and being able to update it and recalibrate it. C is the most important part. Continuous and community-owned and community-operated. Once again, we need to bring evaluation to the ground, not coming up from our ivory towers, not coming up from HLI or SAIL or NeurEPS. This has to be community sourced, community operated, community designed. So, but it's again, there's gonna be a lot of pushbacks, and I've been canceled before. I've been invited and disinvited because they don't like to hear, it makes them uncomfortable to hear about our inadequacies. But the first step is, I always say our preamble is, please leave your hubris at the doorstep. Come in here only if you're ready to acknowledge that we have been contributing to the problems that we complain about. There's no system. We are the system. We are what Harvey Dent referred to, that if you don't die a hero, you live long enough to be one of the villains. We are now one of the villains because we have preserved these legacy systems that continue to harm different communities.
Go for it. No, I was just going to say, I think the disagreement on this panel around this topic of evaluation is sort of looping back to the point I was making earlier, where I think different people have different goals for different types of evaluations. You know, using a benchmark for algorithm selection to say that this algorithm is more efficient or more optimal than this other algorithm is very different from evaluating sort of the effectiveness of something in clinical practice. And so I think that, you know, there's this notion of construct validity of exactly, you know, what is the evaluation meant to be used for, and does this evaluation sort of satisfy that criteria? So I think I just, you know, and now I realize I'm like in defense of benchmarking now, but like, you know, just there's a lot of different reasons that someone might want to evaluate something, and acknowledging that, you know, there's contexts in which a benchmark is suitable and appropriate, and then there's contexts in which an experiment is suitable and appropriate, but we can't do an experiment, so we have to do something in between. And so I just wanted to flag that, you know, every evaluation is not necessarily to demonstrate clinical utility in practice. Sometimes evaluations are meant to just you know, compare two different algorithms for a paper or something, and we just want something that is effective at that and maintaining that kind of ranking of algorithms. So I just wanted to flag that as just the reality of where we're operating when it comes to evaluations.
Thank you. As you all can tell, there is way too much to cover about ethics of generative AI. It could be many hours of a panel. I know we are basically at time. Organizers, can we do?
I mean, I do want to hear from the audience.
Yeah.
So we're going to make this a lightning round.
Yes.
So one sentence responses, and then the rest of it will be discussed over coffee. And Leo, you were right. We don't have enough time. And I would never disinvite you for anything. So if you have an audience question, come up to me. And then if you have something to share, like one sentence response. Okay, I'm going to be over here. I was told to come over. I have a mic. I'll give the mic to the audience member with the question. And please introduce yourself.
Hi, my name is Cindy. I'm a PhD student studying rare diseases and LLM application on it. I'm at UBC, University of British Columbia in Canada. So I really enjoyed the talk. Thank you so much. A lot of insights, and data is gold. But for rare disease, it's really low resource, and there are a lot of confidentiality for data sharing. I was wondering, how did you navigate through the system? Because every institute, they have their own legislation. You have to apply for ethics and stuff. Like for me, my own data set of a small subset of data is even redacted and very limited text data only. It takes me about a year to half a year. So I was wondering some tips for sharing.
I'm guessing that question is for Pranav. Okay, go ahead.
I feel like Emily would be the better person to answer with Undiagnosed Disease Network. But I'll say we work with local champions at those hospitals, and we haven't focused on rare diseases to begin with. I think it brings the challenges that you describe.
Hi, I'm Daniel Wolf from the Computational Precision Health Program, and I didn't raise my hand for the patient advocacy, but actually my experience is much more from that side. So I wanted to press a little on to go one step beyond the just ask patients, to actually thinking about how to meaningfully engage patients in the framing of the research questions and in the evaluation. I mean, I agree with ask, but then I'm curious for some greater detail. Thanks.
I think first it starts with actually taking care of these people. So for example, for I guess this isn't going to be one sentence. I can also talk to you after, but I think it starts with actually having inroads into these communities and having connections, because they're not always going to say yes if someone from the ivory tower is asking, but I'm happy to add additional detail to that later.
I have a quick addition to that, which is that there are these sort of like health system practitioner networks, Health AI Partnership being one of them, and as a prerequisite for some of their programs, especially when it comes to mentorship of lower resource health systems, they will require like sort of like a patient advocacy board or engagement with a patient advocacy group. And I think that, structuring things in this more systematic way and providing resources to structure these kind of patient advocacy engagement pipelines has been pretty successful, at least in this limited setting. So happy to share more information about that particular initiative.
Hi, my name is Paz. I'm an incoming M2. Today I learned more about deregulation, especially in Trump's new One Big Beautiful Bill. I wanted to ask, do you guys think it is a good thing, leaning to more flexibility in AI research and in production, or do you think there is the issue of it being deregulated, us creating more data sets that aren't representative to patient populations and things of that nature? Thank you.
I don't know if you wanted to.
Yeah, I mean, it could be a good thing or a bad thing. It's up to us. To me, it's how we frame our message, and we could align it. We're smart people. We could align it to what they're asking for. But again, amidst this chaos, I keep saying that the light shines brighter when it's darker. So we could actually try to reframe what we want to align with what they want. So what is the impact on the bottom line if we deregulate AI, especially for healthcare? And I think we have surmised, even before the big, beautiful bill, that regulations alone are not going to cut it for AI, and that everyone has to step up. There's a role for patient communities, there's a role for health systems, there's a role for universities, and what have you. So to me, we shouldn't ask, is this a good thing or a bad thing? How do we make it a good thing is the right question.
A quick response on just for generative AI, I think one of the consequences of like the AI moratorium on state legislation, for example, will be that it will kind of create a vacuum, and a lot of the companies will step into this self-regulated regime, and that means that we'll get a lot less transparency in terms of how these companies are doing their evaluations. They will report numbers, and we might not have the transparency to independently assess those numbers, that kind of thing. And also, a lot of the companies' sort of data practices might just be harder for us to identify from the outside, be harder for us to scrutinize and challenge, that kind of thing. And so I think it just gives a lot of leeway to the companies to do as they please. And a lot of the companies claim that they're going to do a lot of good things, but I think it's always good to have regulatory oversight to hold them accountable in that way. And so with that missing, things are going to get a little bit harder to see, less transparency, but also it's going to be harder to hold these companies accountable. They're going to kind of operate independently in a way that they hadn't really before.
Great, thanks. Hey, Josh Fessel recently resigned from NIH. Two things. First of all, a comment, since we brought up the legislative part. If you all don't know, there's an AI caucus in the Senate. It has two co-chairs, Senator Rounds and Senator Heinrich. So in addition to, if you're so inclined to write to your elected officials, in addition, consider reaching out to the co-chairs of the Senate AI caucus, Heinrich from New Mexico, Rounds from South Dakota. That's the comment. The question for this amazing panel was, when we do a clinical trial, we have stopping rules, usually for safety or for loss of equipoise. Either the thing is clearly good or it's clearly futile. From an ethics standpoint, thinking about a generative AI-enabled tool, solution, workflow, whatever that's been deployed, what do ethically informed stopping rules look like? How do you know when to turn it off?
I think some of it follows the same principles. I think one of the ways in which there are stopping points before something is deployed is a ghost period for deployment, which is the way things operate in a lot of health systems, for either research or for productization, and just anecdotally seeing whether people like it, and if there are evaluation benchmarks that have been statically shown to be able to evaluate that task, then that as at least a necessary but not sufficient mechanism.
One of my collaborators, Jessica Dye, has been working on this idea of aggregated individual reporting. So similar to something like, adverse event reporting systems or incident reporting databases. And actually, there's quite a few statistical approaches to data efficient evaluations under this regime where you're getting individualized feedback. And so there is sort of the equivalent of, stopping once you have enough evidence to make a statistical claim against like a hypothesis around a particular amount of data. And so, yeah, just sort of flagging that as like, research that you might be interested in, where under this regime, effectively, you can effectively evaluate a particular statistical hypothesis statement, and you only need X number of data points in order for you to do that, and so you can stop after a certain amount. So I think like statistically, there's quite a bit of work that looks into, when is it a good time to stop collecting individual feedback when it comes to evaluation. So that can definitely apply to the evaluation of AI systems for sure.
I think last question. Oh, sorry.
Can I just say really quick, I didn't hear anyone up here say that and I know I'm not an ethicist by training, I think to venture and be a broken record, I think the statistical arguments for stopping or not are one thing, and I think this conversation needs to be broader, and it needs to have people who are trained in evaluating ethics, because it's an actual discipline. So,
last question.
All right. Hi, I'm Aaron Tierney, and I'm at Kaiser Permanente, Northern California. And my question goes back to the elephant in the room, and because a lot of the things you've talked about, like for instance, like people wanting to change their curriculum really fast, like a lot of these incentives or in a capitalist system are, well, at least in higher education, like teaching evaluations are a very small part of your academic promotion. Like for instance, like you're thinking about AI scribe evaluations, a lot of health systems, they don't purchase licenses for nurses, they only purchase them for physicians. Even like the things that are working, like getting images from other hospitals, like you're using what we would call in health policy research, like mimetic pressure from the health system to like, they need to maintain this competitiveness with their rivals, and so they comply with sharing images. And I just wanted to ask if you had like examples of like how you've worked around kind of this big elephant in the room before, or success stories, or any advice or tips in incorporating in our own like work, whether we're data scientists, researchers, et cetera. But thank you.
Yes, so there are creative ways. I was saying that I hate to toot our horn, but we have organized 100 events in 40 countries under the radar without a single source of funding. All our funding comes locally. We tell them that if you would like to organize an event where you bring together the clinicians and the computer scientists and the social scientists and patient communities, you have to locally source. MIT is not going to go there and give you the funding. And it does a number of things. It empowers them. It makes them own the project so that if it fails, it's not MIT or Harvard failing. But there are ways to do this, but it's going to be outside of your job description. And we work with hundreds of students from around the world, and it's outside the scope of their coursework. But you could see that it works, that they are valuing their interaction with us in being part of our research community. The question is, so these innovations are happening. So don't get me wrong. There are so many magical moments that are happening right now. You just haven't heard of them because they've maintained to be low profile. Our job is to let these innovations at the margins trickle into the center. Our job is to, and it's hard, again, it's paralyzing. How do how do you dismantle power structures in academia? If you try to say that you're doing that, people are just going to mute you because they don't want to hear this because they know it's not going to work. But what we have been doing is to disrupt power structures within the smallest units. So what are the fractals of the power structures in your school, in your organization, in your startup, in your foundations? And maybe you could start there. And what we're hoping, it's a leap of faith, that this challenging of power structures, if it's successful in the smallest units, would somehow spill over and, like a good virus, infect the rest. And before you know it, academia is taken down. I really think that if you fix academia, you've solved about 50% of societal problems.
Okay, I just had a quick comment, which is learning from other industries and other fields. I've been, so I mentioned the sort of adverse event reporting and monitoring. A lot of that is from, vaccine monitoring and, VAERS, like adverse event reporting systems there, or for pharmaceuticals and sort of how that's monitored. Of course, it's not one-to-one, but a lot of other fields. I learn a lot from like the sort of climate change, environmental justice movement, where a lot of their goals are also, trying to think about things scientifically, but also trying to have implications with respect to policy and all these other things, funding, et cetera. And so just thinking through other disciplines or other communities and how they've navigated that elephant in the room has been very helpful in terms of creating a plan as to what we should do in the AI space.
Awesome. With that, just want to thank all of the panelists for really challenging us to think broader than kind of the normal technical conversations that we have. So let's give them all a round of applause. And with that.
All right. Thank you all for our first fantastic day. A quick recap. We had 3 awesome keynotes for today from Maia Hightower, Ida Sim, who told us about some of the practical challenges with real-world deployment of the AI health systems that we are all thinking about developing or are developing. Guillermo Sapiro giving us real-world examples of innovation in AI and health. We had some awesome doctoral symposium speakers who gave us more examples of innovation, which we will see more of next in the upcoming poster session. So please hang back for the poster session from 4 to 5. We wrapped up the day with the GenAI and ethics panel, where we talked about challenging status quos. So regulation and deregulation, thinking about benchmarking and evaluation, thinking about the broken legacy systems in which we're intending to deploy novel systems, and a plug to reach out to your elected officials to make your voice heard. So overall, a really great first day of getting a handle on the innovations and challenges in health AI. The sneak preview for tomorrow will start off the day with a year-end review, which will be kind of an overview of the literature from AI health for the year 2024. We'll have 2 keynote speakers, Judy Gachoya and Pete Solovitz. We'll have research roundtables, a panel on translational research in a changing world, and a fireside chat with a patient advocate and security researcher. So please hang on for the doctoral poster session, and we'll see you again back tomorrow. Thanks.